Ma'am, we are live in 3, 2, 1. Please start, ma'am. We are live.
Yeah. Namaskar and good evening, everyone. I welcome you all for today's webinar on updates in genitourinary cancer. And for this, I would like to invite Dr. Priyanshu Chaudhary, Consultant Medical Oncology, Shalby Hospital, Mohali, to set the ball rolling and to carry out the further proceeding. Over to you, sir.
Hi, good evening, everyone, and welcome to today's seminar on genitourinary cancers. So we'll be discussing renal cell cancer, bladder cancer, and prostate cancer. So these are the three common genitourinary cancers we encounter every day. And the treatment paradigm in all these cancers has evolved tremendously in the last 3 to 5 years, I would say, with immunotherapy coming up as first line in RCC in almost all the cases of metastatic RCC, and PARP inhibitors coming in prostate cancers, and ADT, different forms of ADT coming in prostate cancers, as well as immunotherapy both in frontline as well as maintenance in bladder cancer. So we'll be dealing with these cancers in the setting of first line, second line, and beyond, and we'll be discussing the latest treatment updates as well as the treatment guidelines. And for that, I would like to invite Dr. Piyush for the first session. That would be on perioperative systemic therapy for bladder cancers. So welcome, Dr. Piyush. I have your slides, so I'll be sharing your slides.
Okay. So good evening, everyone. And thank you, Dr. Priyanshu, for giving this opportunity to discuss about the role of neoadjuvant and adjuvant treatment in urothelial carcinoma, upper tract urothelial carcinoma. So as we know that the neoadjuvant or adjuvant therapy for high grade, so worldwide there are approximately 6 lakh new cases of urothelial carcinoma, and of these every year 2 lakh death because of the urothelial bladder carcinoma. And so we all know that we treat it as per the muscle invasive or the non-muscle invasive, according to whether it is muscle invasive or it's a non-invasive disease. And there is a multimodal modality approach for treatment of these disorder, like a neoadjuvant chemotherapy followed by radical cystectomy. And in some patients who are not candidate for radical cystectomy, or those who are not willing for radical cystectomy, we go for we retain their bladder and do maximal tumor resection of bladder tumor followed by chemoradiotherapy. So what are the neoadjuvant and adjuvant therapy comparison and benefit and the concern? So how to select patients for the neoadjuvant therapy, and what is the indication for cisplatin, and any trials of neoadjuvant therapy we are going to discuss, and the ongoing trials of neoadjuvant chemotherapy as well as immunotherapy, that to any role of immunotherapy. And in adjuvant, we will discuss about trial data, nivolumab, FDA approval, and targeted treatment. Next step. So what are the challenges? So it's a rare population biopsy sample. They are sometimes scant in amounts, difficult to undergo testing, and it is sometimes difficult to stage, and in some cases we have upstaging. And the modest prospective data in the neoadjuvant setting, and expected decline in renal function post-operatively, and in sometimes pre-operatively also in some patients. So there is a better prospective data in the adjuvant setting, but chemotherapy may longer be feasible in some cases if there is an impact on the renal function. Next slide. So it is often upstaged from like clinical non-muscle invasive to pathological muscle invasive disease. So this is a diagram which is showing the overall T-stage discrepancies in the urothelial carcinoma of the bladder, pelvis, and the ureter. So we can see the bladder, the total 3,747. So in bladder, they remain in the same stage, while it's upstaging in 25.4% and downstaging in 13.4%, and almost similar percentages in the pelvis and the ureter. So mostly we can see there's a upstaging. So who gets this urothelial carcinoma? Who is cisplatin fit? So average age is 73 years, and most of these patients, they are not fit for cisplatin. Male predominant, smoking related, and they have a comorbid condition like they have a hearing loss, renal issues, neuropathy, poor functional, poor performance status, and all patients, they are not upfront eligible for the treatment with cisplatin. Some have renal dysfunction. So next slide. So what is the pathological CR to neoadjuvant chemotherapy in urothelial carcinoma bladder cancer? So we can see that around 81,000 new bladder cases annually they occur, and the urothelial carcinoma, and in PCR to neoadjuvant chemotherapy, that is around 9 to 14%, and to upper urinary tract urothelial carcinoma, it is around 7%, and in bladder it is 93, and PCR is in around 38%, followed by, we can, it depends upon their biology as well as in the stage. Next. So this is a retrospective studies on the neoadjuvant chemotherapy in upper urinary tract urothelial carcinoma. So we can see the retrospective neoadjuvant studies in which they have taken patients with a pathological T0N0, and in those patients who have PT1 and nodal 0, 5-year, we can see the CSS in those patients with 15 NAC patients, they were enrolled, and then in PT0 and 0 there were 47 with nodal of N0 and node unspecified in 47. So we can see that overall survival of 38 months, and the p-value is 0.015. So mostly we can see the difference in the overall survival that was in those patients who have a PT1. So we can see, like in the 51 neoadjuvant we have seen, and 5-year survival of 71%, and 5-year overall survival of 35%, and p-value of 0.032. Next slide. So these are the retrospective studies on neoadjuvant chemotherapy in upper urinary tract urothelial carcinoma. So patients, like we can see that neoadjuvant chemotherapy, they in 231, and in T0 there were 6.1% of the patients, and when we have taken in the T1, so in T1 there were 63 and 75%, and nodal N0 or NX, and in 25 enrolled of this neoadjuvant chemotherapy, PT1 was 52, and 0 death, and p-value significant of 0.05. So next slide. So prospective neoadjuvant chemotherapy trials. This is studies by Margulis, Coleman, McConkey, and Hoffman synthesis. So they have used MVEC regimen, and 4 cycles. Total number of patients, there were 29, and 4 cycles were given. PCR was in 14% of the patient, and YPT1 it was in 62% of the patient. Relapse-free survival was it was 60. Event-free survival, it was 65.8%. So in Coleman, there were enrolled 53 patients, and gemcitabine and cisplatin. Cisplatin was given split in day 1 and day 8, 35 milligram per meter square, and gemcitabine 1000 milligram per meter square day 1, day 8, and 4 cycles were given. 83% of the patients they received 4 cycles, and PCR that was in 19% of the patient, and overall survival of 2 years, 2-year overall survival in 89% of the patients. So McConkey, they have used bevacizumab. Next slide. So neoadjuvant treatment response and the survival benefit. So evaluate as PT1 and 0 as the endpoint for the clinical benefit, and we can see the PFS Hello.
Yes, you are audible, Dr. Piyush, you are audible.
So we have seen the PFS and the overall survival benefit. So we can see that in those patients who have more PT2 more than or T2 disease, T2N1 N0 disease, we can see in the green line, we can see their PFS probability. We can also see that in patients with PT0, there was not much difference, and in PTA and T1 disease, we can see the orange graph is showing this, and overall survival, definitely we can see that in patients with PT2 N0, the overall survival benefit that was significant with the use of the this. Next slide. So perioperative chemotherapy, the cisplatin eligibility declines following nephroureterectomy. If after pre-op, so if 58% patients are eligible for cisplatin, then after nephroureterectomy after surgery, the percentage of population that declines to 15% of population who are eligible for cisplatin. So that population increases. So another future trials, which are the ongoing trials, are with GEMSIS. We all know that with a neoadjuvant versus adjuvant chemotherapy, it's a trial which in Netherlands, and there's some ongoing trying with combination of the chemotherapy as well as immunotherapy with durvalumab, with toripalimab, with durvalumab, with the MPEG regimen, durvalumab with gemcitabine. So these are the ongoing trials. So it's a phase 2 trial, EA8141, in which neoadjuvant chemotherapy that was followed by extirpative surgery in high-grade urothelial carcinoma. So the 36 patients, they were enrolled in this, and in arm A, they were given MVAC with pegfilgrastim for 4 cycles, and in arm B, those patients with creatinine clearance more than 50, they were taken in arm A, and with creatinine clearance between more than 30, they were enrolled in this arm B, and they have used carboplatin instead of cisplatin because of ineligibility. Gemcitabine and carboplatin was used for 4 cycles. So the conclusions are that feasibility of a prospective, so it was a trial, and its MVAC was safe and well tolerated. And with MVAC PCR, when we achieve PCR with downstage, and gemcitabine carboplatin arm not feasible as written, likely in part because of the narrow creatinine clearance window and lack of enthusiasm. Complete response rate was 14%. It's the study for next slide. So this is also now we have basically 2 new adjuvant option. One is a gemcitabine cisplatin, and another one we have is MVAC, methotrexate, vinblastine, and doxorubicin, and cisplatin. So in patients who have a good performance status, we prefer giving MVAC, and in those with poor performance status, we can give gemcitabine cisplatin. Although the efficacy of gemcitabine cisplatin, it is comparable to MVAC, but in patients who are cisplatin ineligible, although the data is not much convincing for the carboplatin, but we can combine gemcitabine with carboplatin, or if the creatinine clearance is between say more 40 around 50, then in those patients we can use in some patients we can use split doses of cisplatin into day 1 and day 8 also. So this is a POUT study. It was an open label randomized controlled phase 3 trial, which was conducted at 71 hospitals in the UK. So patients with invasive urothelial carcinoma, they were taken, and block radical nephrectomy was done, and they were eligible for chemotherapy, and they were enrolled within 90 days of nephroureterectomy. So performance status was 1, and total number of patients was 260. So in group in platinum-based chemotherapy, they have taken type as according to the GFR. They have used the chemotherapy cisplatin-based to 4 cycles, and in another arm they have used only surveillance. Follow-up was done after every 3 months for 1 year, and then every 6 months to 36 months, and after that annually. So primary endpoint was disease-free survival, and secondary endpoint was metastasis-free survival, overall survival, compliance, acute and late toxicity, and patient-related quality of life. Next slide. So we can see that the 3-year disease-free estimate was 71% in chemotherapy arm, and with surveillance it was 46%. So absolute difference of around 25% in this trial. Next slide. So overall survival that improved significantly with chemotherapy, but not statistically significant, and hazard ratio of 0.7, and post-recurrence systemic therapy was given in 41. After receiving chemotherapy, surveillance was in 45, and chemotherapy was given in 18 patients. Next slide. Next slide. Just so phase 3 trial data of the adjuvant chemotherapy in urothelial carcinoma. So this is an ambassador trial. Total number of patients, there was 739, and IM Viger 010, checkmate 274 nivolumab versus placebo. So in ambassador, the update was positive with nivolumab. Next. So checkmate 274. So this is for adjuvant nivolumab versus placebo after radical surgery, plus, or in some cases we have given new adjuvant therapy in high risk urothelial carcinoma. So both patients who have received neoadjuvant chemotherapy and those who haven't received neoadjuvant chemotherapy, they both have been enrolled in this study. So it was an international randomized phase 3 trial. Patients with YP YP T4 any neoadjuvant cisplatin chemotherapy, and ineligible or refused cisplatin-based chemotherapy, and patients who have underwent radical surgery less than 120 days and disease-free within 4 weeks of the study dosing. So total 709 patients, they were enrolled in the study. Primary endpoint was disease-free survival, intention to treat population, disease-free survival in all randomized patients with PDL1 of more than or equal to 1%. And secondary endpoint was known urothelial tract recurrence-free survival and disease-specific survival, overall survival. So study was stratified by the PDL1 status, either less than 1% or more than 1%. And whether previous they have received neoadjuvant cisplatin-based chemotherapy and the nodal status. So 353 patients, they received nivolumab in a dose of 240 milligram 2 weekly, and in placebo in another half in 356 patient, and treatment was for to 1 year of the adjuvant therapy. Next slide. So we can see the these are the characteristic that so this is the coming to the DFS, and in so we can skip this side. I think it was coming to the disease-free survival in intention to treat population. Events 170 events in out of 353 patients, and 214 patients on placebo, and DFS was 12-month DFS was 62% in nivolumab arm and 46 in another arm. And in DFS in patients with PDL1 more than or equal to 1%, that was 67% at 12 months in nivolumab arm, and in another it was 45 with significant p-value of less than 0.001, hazard ratio of 0.55. Next slide. So disease-free survival by the subgroups that we can see in all of these, that in we can see this forest plot, and we can see that in the renal pelvis and in the ureter and the bladder, that it is toward the right. So we can see that the hazard ratio 1.25 and 1.56 in both renal pelvis and ureter. So but in the urinary bladder, it is 0.6 to the hazard ratio. And in those patients who have previously received cisplatin therapy, definitely the hazard ratio is 0.52. And in those patients who haven't received any therapy, it is 0.92. And also depending upon the geographic region, like in the Asian population, it is 0.85 for the Asian subgroup of the patient population. Next slide. So it's a phase, another study with immunotherapy atezolizumab. The phase 3 IM Viger 010. So with DFS with adjuvant atezolizumab versus observation in patients with high risk muscle invasive urothelial carcinoma. So we can see that in this study, median DFS that was with atezolizumab, it was 19.4 and 16.6 in another arm. And so there was no difference in any clinical subgroup, including the PD-L1 expression level. We can also see it through the graph. And the p-value was also not significant. It was 0.24. Next slide. So IM Viger 010, same. The survival outcomes with atezolizumab versus observation by post-surgical circulating tumor DNA status. So we can see that in the first graph, the DFS probability that in patients with circulating tumor DNA positive, the hazard ratio was 0.58, and in those subgroup with circulating tumor DNA negative, hazard ratio was 1.14. So it's not much beneficial. And in the OS probability, we can see that in those patients with circulating tumor DNA positive, the similar hazard ratio 0.59, and in patients with circulating tumor DNA negative, overall survival, we can see hazard ratio of 1.31. So not much benefit in this. And the median overall survival in patients with circulating tumor DNA positive, that is 25.8 months, and in circulating tumor DNA negative, that is not reached yet, and in the observation arm, so in negative patients circulating tumor DNA negative, that is not reached, and in the ctDNA positive, it is 15.8 months. Next.
That's the last slide,
Next
Dr.
slide.
Piyush. This is the last slide.
Okay. Thank you.
Thank you, Dr. Piyush. I have a little bit questions for you. I mean, what is the preferred treatment, perioperative treatment which you do, whether it's a pre-op or a peri-op or a post-op? And second is, what are the regimens which you use? Are you more comfortable with GemCis or dosed in MVAC?
Dr. Pranshu, in patients with muscle invasive, definitely I will give neoadjuvant chemotherapy, and I'm more comfortable with using gemcitabine and cisplatin if patient is cisplatin eligible. And if patient is not cisplatin eligible, then either that patient is because of any comorbid condition like decreased hearing or age or creatinine clearance. But if the patient is not eligible for cisplatin, then in those patients I have used carboplatin. Dosed dense MVAC that I have used in just 1 or 2 patients till now. So more comfortable using gemcitabine cisplatin in this.
Okay, thank you so much.
Okay.
Over to the organizers. So our next presenter is Dr. Mukesh. Dr. Mukesh is assistant professor in All India Institute of Medical Sciences, Bathinda. So Dr. Mukesh will be presenting, first-line therapy for advanced urothelial cancers. Welcome, Dr. Mukesh, and over to you.
Yeah. Good evening, everyone. Good evening, Dr. Priyanshu. Can the organizers please play my slides?
I'll request the tech team to kindly.
Yeah. Thank you. So the topic given to me is selecting first-line therapy for advanced urothelial cancer. The need of this question is because of the coming up of the immunotherapies, the data regarding immunotherapy which we are getting in the metastatic and in the settings. So in the second line settings, so it has come up to the point of using them in the first line settings in some selected patients. Next slide. Next. So we will start with the case discussion. There's a 73-year-old man presenting with dysuria and hematuria diagnosed with metastatic urothelial carcinoma. His ECOG performance status is 1. GFR is 70 ml per minute. There is no other significant comorbidities. The CT scans of the chest, abdomen, pelvis are showing liver and lung mets. There is FGFR 2 or 3 mutations, alterations are not there. PDL1, the CPS score is 15. So what should be used in these kind of patients, whether they are cisplatin eligible or ineligible? So if we see the criteria of cisplatin ineligibility, the performance status 2 or more, GFR 60 or less, by that definition, the patient becomes cisplatin eligible. Next. So in the cisplatin eligible patients, still the guidelines recommend using gemcitabine and cisplatin based chemotherapy, or in some cases DDM-VEC as the preferred first line settings, followed by avelumab maintenance. But in the induction regime, there is no role of immunotherapies as such in cisplatin eligible patients. So talking of cisplatin ineligible patients, so there is the opportunity to test the immunotherapies in first line setting, because the main isn't effective in cisplatin eligible in metastatic urothelial carcinoma is cisplatin, which improves the survival. However, more than 50% of patients are ineligible due to various comorbidities, as I have already discussed, due to performance status, renal dysfunction, neuropathy, hearing loss, or heart failure. So in the cisplatin ineligible patients, the outcomes are usually poor. About 1/3 of patients are never treated with any agent. Next slide. The median survival of the gemcitabine and carboplatin, which we are using, which we were using, is about 9.3 months. Next. So these immune checkpoint inhibitors are a new standard of care for cisplatin ineligible metastatic urothelial CA, as shown by the two studies, IMvigor 210 and Keynote 052. In the first study, atezolizumab was used. The median overall survival was 16.3 months. 1 year OS data was 58%. It was approved in Feb 2017. And the second is Keynote 052. The pembrolizumab was used. The median OS was 11.3 months. And overall response rate were 29%. Next. So first, talking about the IMvigor 210 study design, which was the basis for accelerated approval of atezolizumab. It was a single-arm phase 2 study with 2 cohorts. Cohort 1 was cisplatin ineligible patients, and the second cohort was who were already treated with the platinum agents. So in both these cohorts, atezolizumab 1200 mg 3 weekly was given until progression. So the primary endpoints were overall response rate, and secondary endpoints were OS and PFS data and safety data. Next. So these were the ineligible patients were ineligible because of age, because of renal dysfunction, because of performance status. Next. So on the long-term follow-up, 1 year OS data was 58%, 2 year OS data was 41%. And this is the graph showing in the various subgroups by the performance status, cisplatin eligibility criteria, primary tumor site, as whether it was lower urinary tract or upper tract, site of metastasis, it was liver, lymph node only, or other visceral mets, by the status of the PDL1, either it was less than 5% or more than 5%. So in almost all of the subgroups, it showed benefit. Next. So talking of Keynote 052 study, it used pembrolizumab as first-line therapy for cisplatin ineligible advanced urothelial carcinomas. It was also a single-arm phase 2 study. Patients with the advanced bladder cancer with no previous chemotherapy, COG 0 to 2, and ineligible for cisplatin based on any of the criteria was taken. So pembrolizumab 200 mg 3 weekly was given, and patients were followed for 24 months for progression or intolerable side effects. So primary endpoint was overall response rate, and secondary were PFS and OS data. So patients were also stratified by PD-L1 positivity. Next. So on long-term follow-up, the 12-month OS data is 46.9 months, percent, and median overall survival was 11.3 months. If we stratify by CPS score, in less than 10%, it doesn't have much benefit with median OS of 9.7 months, which is comparable to the gemcitabine and carboplatin. And in the CPS more than 10% category, it has a median OS of 18.5 months. If we stratify by age less than 65 and more than 65, it showed more benefit in the less than 65 age group, more benefit in the 0 and 1 ECOG performance statuses, and more benefit in the lymph node only mets patients. Next. So the use of pembrolizumab requires the use of an FDA-approved companion diagnostic test to determine PD-L1 levels in tumor tissue. And pembrolizumab is indicated for treating patients with metastatic urothelial not eligible for cisplatin-containing chemotherapy and whose tumors express PD-L1 CPS more than 10%, as shown by the previous study, as determined by an FDA-approved test, or in patients not eligible for any platinum-containing therapy. So if the patient is only cisplatin ineligible but is eligible for carboplatin, then the CPS should be more than 10% for using pembrolizumab. But if patient is ineligible for all the platinums, then we can use the pembrolizumab regardless of the PD-L1 status. And atezolizumab is indicated for treating patients with metastatic urothelial not eligible for cisplatin-containing chemotherapy and whose tumors PD-L1 CPS score is more than 5%. Or same as in pembrolizumab, the patients who are not eligible for any platinum-containing therapy, then we can use the atezolizumab regardless of the PD-L1 status. Next. So this is the phase 3 IM Viger 130 study. One arm was given atezolizumab plus platinum. Second arm was given atezolizumab monotherapy. Third arm platinum monotherapy or platinum with placebo. Next. So this is the median OS data of combination arm in which we used atezo plus platinum 16 months compared to 13.4 months in the placebo plus platinum group with a p-value of 0.027%. Next. So in interim OS data, atezo versus platinum by PD-L1 status. In the immune score 0 and 1, which corresponds to less than 5% expression, the HR value is 1.07, which is not significant. The median OS is 12.9 months in the platinum group, platinum plus placebo group, and 13.5 months in the atezo group. But this data, this is not significant. In the PD-L1 IC2 and 3 means score of more than 5%. The median OS is 17.8 months in the platinum group, and it is not yet reached in the atezo group, but the OS events, the 33 events have occurred in the atezo group and 42 in the placebo group with the HR value of 0.68%, which shows a significant benefit. Next. Next. Yeah, so coming to the Keynote 361, which used first line pembro, chemo, or both in advanced urothelial carcinoma. So there were 3 arms. In the first arm, we used pembro 200 mg 3 weekly plus gem plus cis or carbo. In the second, only pembro. In the third arm, only chemotherapy with gem cis or gem carb. In the pembro plus chemo group, pembrolizumab maintenance was also given for up to 29 cycles. Next. So in the intention to treat population, in the pembro group, the median OS is 17 months. In the chemo group, it is 14.3 months with HR value of 0.86% and a significant p-value. The 12 months overall survival is 61.8% in the pembro group versus 56% in the chemo group. Next. So after stratification by the CPS score of 10, in the CPS more than 10 group, in pembro had a median OS of 16.1 months, and chemo had a median overall OS of 15.2 months with HR value of 1.01, which is not significant. Next. So coming to the Javelin study, which was a practice-changing study which introduced the Valumab in the guidelines, though there were two groups. The patients with unresectable locally advanced urothelial cancer who attained CR, PR, or stable disease with 4 to 6 cycles of standard first-line chemotherapy, either Gemcis or Gemcarb, 4 to 10 weeks after the last dose of chemotherapy. Either the patients were given Avelumab 10 mg per kg 3 weekly plus best supportive care, or patients were given only best supportive care until disease progression or unacceptable toxicity. The primary endpoint was OS in all randomized patients and PDL1 positive patients. The secondary endpoints were PFS and overall response rate and safety and tolerability. Next. So in the Avelumab group, the median OS is 21.4 months. In the best supportive care, 14.3 months, achieving a significant benefit of 7 months with a p-value of 0.001, establishing the role of Avelumab in the maintenance setting. Next. So the previous OS data was irrespective of PDL1. If we stratify it in the PDL1 positive population only, in the best supportive care, it is 17.1 months and not yet reached in Avelumab group. But after 12 months, the median OS is 60% in the best supportive care group and 79% in the Avelumab group, showing a significant benefit of 19% after the completion of 1 year in the overall survival. Next. So Avelumab received FDA approval for urothelial carcinoma maintenance 2 years back. Next. Next. So what are the pros and cons of immunotherapy versus platinum? Because in the cisplatin ineligible group, we have the option of using either gemcitabine and carboplatin based chemotherapy or single agent immunotherapy, atezolizumab or pembrolizumab. So how to decide? The pros are high probability of achieving disease control, allowing the rapid transition to maintenance immunotherapy after 4 to 6 cycles, and it is ideal for symptomatic or rapidly progressive disease. And the cons are short duration of response, chemotherapy related toxicity, and not all patients are eligible for chemotherapy. Next. So same, the responses are higher in the first line, responses are durable, quality of life is improved. These are the pros of immunotherapy, using immunotherapy rather than chemotherapy in the first line. The responses are higher as compared to second line, durable responses are there, quality of life is improved. The cons are lower likelihood of response as compared to platinum based chemotherapy. There is a risk of disease progression and early death, and PDL1 expression has not been able to be a useful biomarker in these settings. Next. And next, thank you. That's all I think.
Thank you, Dr. Mukesh. And over to the organizers. Think. Next. So next, I think so I'll be presenting the role of maintenance therapy in advanced urothelial cancers. We have done the first line therapy for advanced bladder cancer. So now we'll be dealing with a little bit of maintenance. We know the incidence we have discussed as 10th most common worldwide. Most common histology is transitional cell. In India, it is the 17th most common cancer, around 4% of all cases. 21,000 cases per year, around 11,000 deaths, and 5-year prevalence of approximately 50,000. So the Indian figures differ from the Western literature in two aspects. One is the incidence of smoking, and another is the male to female ratio, which is higher in the West. So this was the stage distribution of urothelial cancer in a 2013 study by TMH, which showed that around 17% of the cancers were metastatic at presentation, and another 35% were locally advanced breast cancers. Rest were non-muscle invasive bladder cancers. So if we see the timelines of approval, in the 1970s, first came cisplatin, then 80s it was MVAC, then again the carboplatin and gemcitabine came in the 2000s. In 2017, for cisplatin ineligible and PD-L1 positive patient, pembro and atezo were approved. While just only last year we have the latest approval of avelumab as a monotherapy for the first line maintenance in patients with locally advanced or metastatic bladder cancers who have not progressed following a platinum-based chemotherapy. What are the challenging in optimizing first-line therapy is that the patient attrition is pretty high in the second or third line. This is a real-world data which shows that almost all patients receive first-line chemotherapy, but it drops down to less than 15% in the third line. If we see majority of the patients receive platinum-based therapy in the first line, approximately 50 to 70% are eligible for cisplatin, and those who are not eligible for cisplatin, among them around 75% are able to receive carboplatin. The clinical decisions which influence the platinum-based therapy are the performance status, renal function, neuropathy, age, and hearing status. So urothelial cancers are chemosensitive tumor. The first line platinum-based chemotherapy is a standard of care and produces good response, but the response is not usually durable. So we see around 50 to 80% of the patient achieve disease control with first line platinum chemotherapy-based agent. However, OS is limited by the chemotherapy resistance. So the second line therapy is initiated on disease progression. So with this platinum-based chemotherapy, we expect a median OS of around 14 to 15 months, while with carboplatin it is around 13 to 14 months. So what are the treatment approaches to maximize overall survival? So in patient who are cisplatin eligible, a first line chemotherapy, after that a wait and watch policy can be applied, or then we can go for a switch maintenance to immunotherapy, or you can have a continuous maintenance with along with the first line chemotherapy followed by maintenance immunotherapy, and on progression initiation of a second line chemotherapy. So if we see the continuous maintenance therapy with chemotherapy and immunotherapy combination, the treatment strategy was utilized by 3 trials: IM Vigor 130 with atezo plus chemotherapy, Keynote 361 with pembro plus chemotherapy, as well as Danube durvalumab plus tremelimumab. So out of these 3 trials, 2 were negative trials, and even with IM Vigor 130, there was no significant differences OS at the second interim analysis. So all these trials did not meet their overall survival endpoint. So what is the other therapy is switch maintenance. which has this hypothesis has been applied to the Javelin bladder 100 trial. So we'll study this trial. The rationale for first-line maintenance therapy after chemotherapy is that platinum-based chemotherapy has direct cytotoxic activity, which may control or reduce tumor burden and prime the tumor for immune checkpoint inhibitor therapy. So the first-line chemotherapy reduces baseline tumor size and primes the tumor for ICI treatment, while the maintenance therapy may delay disease progression and the need to start a second-line therapy. So coming to the Javelin bladder 100 trial. So this was a phase 3 randomized open-label study in which induction chemotherapy in unresectable, locally advanced or metastatic urothelial cancers with measurable stage 4 disease was given. The patient received 4 to 6 cycles of cisplatin plus gemcitabine or carboplatin plus gemcitabine. After a treatment-free interval of 4 to 12 weeks and a radiological assessment of response, patient who had a stable disease, partial response, or a complete response were randomized 1:1 to avelumab 10 mg per kg every 2 weeks plus best supportive care or best supportive care alone until progression, unacceptable toxicity, or withdrawal. The primary endpoint was overall survival. The secondary endpoints were PFS, overall response rate, time to response, response duration, disease control, safety, and tolerability. So it was a phase 3 trial, 370 locations. India was also one of these locations. It was a randomized trial, open label, 700 patients, locally advanced or metastatic urothelial cancers. So the median age was 68 years, 76% were males, around a majority of the patients had a performance status of 0 to 1. The visceral metastasis was present in around 55% of the patient. 52% patient received gemcitabine plus cisplatin, while 42% received gemcitabine plus carboplatin. So if we see the overall survival results, the overall survival in the overall population, the median OS was significantly prolonged in the avelumab arm, 23.8 months versus 15 months in the best supportive care alone arm. And the hazard ratio was 0.76 and a significant p-value. So if we see, it showed a significantly prolonged OS. Around 50% of the patients were alive at 24 months. And if you see the PFS, the median PFS was more than double, that is 5.5 months versus 2.1 months in the best supportive care arm. And again, it was the hazard ratio was 0.54, which was also significant, which had a significant p-value. Then they did a subgroup analysis. OS in the PDL1 population was even higher, 30.9 months, the median OS versus 18.5 months. Again, significant p-value. Also, the PFS was also significantly prolonged, 7.5 months in the PDL1 positive population compared to 2.8 months in the best supportive care alone arm. So we see the OS by the best response to first-line chemotherapy. We see the patient who had a complete response to first-line chemotherapy, they did quite well. A median OS reaching almost 40 months, while those who had a partial response had a median OS of 19.2 months, while who had a stable disease had a median OS of 22.3 months. Similarly, the investigator assessed PFS by best response to first-line chemotherapy. In patient who had a complete response to chemotherapy, the median PFS was 9.5 months. In patient who had a partial response, it was 3.8 months, and in patient who had a stable disease, it was 5.6 months. Now coming to the most common adverse effects, majority of the patient had some grade of side effects, but the grade 3 side effects were less than 5% in all the arms. So the main side effects were arthralgia, pruritus, asthenia, diarrhea, fatigue, pyrexia, UTI, back pain, constipation, and anemia, but most of these were well managed with supportive care. So what were the treatment sequencing? What were the later lines of therapy which the patient in the avelumab arm received after they had progressed on avelumab? So at the time of data cutoff, around 43 patients out of 350 were still receiving avelumab, while 307 patient had discontinued. So again, in the second after this avelumab maintenance, 75 patients received re-challenge with platinum-based chemotherapy. 11 patients received further immunotherapy in pembro, atezo, and nivolumab, while 99 patients received other forms of chemotherapy like paclitaxel, enfortumab, gemcitabine, docetaxel, pemigatinib, etc. So coming to overall survival in the avelumab arm by the type of second line chemotherapy. So it did not usually differ what kind of therapy the patient received in the second line. All of them had a similar median overall survival. So very important subgroup analysis presented in ASCO GU 2022 was the Asian subgroup analysis of the Javelin Bladder 100 trial. So around 21% of the overall population of Javelin trial had was the Asian subgroup, and around 147 patients were in this subgroup, and 73 received avelumab, while 74 had a best supportive care alone. So if we see again, the median overall survival was again prolonged in this subgroup. Median overall was 25.3 months in the avelumab arm versus 18.7 in the best supportive care alone arm. A hazard ratio of 0.74, and if we see in the PDL1 population, it was again significantly prolonged, 26.1 months compared to 19.4 months in the best supportive care alone arm. If we see the median time to end of next line therapy, it was also significantly prolonged in the Asian population compared to those who received best supportive care alone arm. It was around 18.5 months versus 8.8 months in the best supportive care arm. More patients achieved an objective response and disease control with avelumab maintenance treatment. Around 50% of the patient had either a stable disease, 42.5% of the patient had a disease control rate, and almost 50% had a stable disease or a responding to response to avelumab in this Asian subgroup analysis. Although most patients experienced treatment-related adverse effects, but there were minimal grade 3 events, and there was one death in the avelumab arm and one death in the best supportive care arm. 27% of the patient had any grade immune-related adverse effect, but they were well managed. So what are the guidelines which we now see that almost all the guidelines like NCC and ESMO and European Association for Urology, all of these mention avelumab maintenance as a category 1 in patients who have not progressed on chemotherapy. Similarly, it is both in cisplatin eligible as well as ineligible. So it has one of the highest level of evidence for maintenance therapy in patients who have not progressed on frontline chemotherapy. Similarly, these guidelines again NCCN mentioned even in second line therapy we have these therapies which are available like GemCarb, GemCis, Dosdes MVAC, or enfortumab vedotin or adafitinib. So if we see the sequential therapies and the overall survival, if we see with the standard first line chemotherapy, we expect a 3 to 5 months of a median PFS, followed by a TFI of 4 to 10 weeks, and followed by a median OS of 21.4 months, leading to an estimated median overall survival of 26.5 months, which is the highest if we see the sequencing of various therapies in metastatic bladder cancers. So if we see overall survival of close to 30 months with avelumab maintenance in patients who are put on maintenance avelumab after first line chemotherapy. To summarize, if we see the long-term follow-up from Javelin Bladder 100 trial of more than 2 years duration continues to show prolonged median overall survival and PFS with avelumab first line maintenance compared to best supportive care alone. And the primary endpoint is the overall survival, which was median overall survival was 23.8 months, almost 2 years in the avelumab arm. And the overall survival rate at 2 years was 49.8%. That is almost half of the patient were alive at 2 years. And the 2-year PFS rates were 23.4% in the avelumab arm. Overall survival was prolonged with avelumab first line maintenance therapy, despite a high proportion of patients treated with best supportive care alone receiving a subsequent anti-cancer therapy, particularly PD-1 or PD-L1 inhibitors. And the long-term safety of avelumab first line maintenance was also demonstrated with 20% of the patients receiving more than 2 years of treatment and a low rate of discontinuation due to treatment-related adverse events. So thank you for listening to this talk. And I would like to invite Dr. Navdeep for the next talk. And we'll be moving to the treatment refractory advanced urothelial cancer, what to do after chemotherapy and immunotherapy. Over to you, Dr. Navdeep.
Okay, I hope my slides are visible.
Yeah, they are visible.
Okay. Now we will discuss about the treatment refractory advanced urothelial cancer, what to do after chemotherapy and or immunotherapy when the disease has progressed. We know all that we already discussed that these historically these tumors are considered chemotherapy sensitive, and the urothelial cancer, they carry a high mutation burden. And since 2016, the role of immunotherapy has come into role in both first line as second line as well as maintenance. Immunotherapy, it remains one of the most important achievement, but still minority of patients respond. So next. What are the other agents that we can use beyond the checkpoint blockade? We can use a targeted therapy in the form of dafitinib, because almost 10 to 15% patient of advanced urothelial cancer, they can have this FGFR2 mutations. And the other are the antibody drug conjugates in the form of enfortumab vedotin and sacituzumab govitecan. First, I will discuss about dafitinib. It was studied in a phase 2 study, which was BLC 2001. In this, the patients who were having metastatic disease or surgical unresectable disease, they are screened for FGR mutations. And initially, two regimes were used. One was a daily 10 mg per day. One regime was 10 mg day per day for 7 days on and off. The other regime was 6 mg per day. On the basis of these regimes, on the basis of the interim analysis, the final regime which was used was 8 mg per day, and we can be titrated up to the 9 mg per day. And total patient studies were studied were 101. So coming in the baseline characteristic, the median age was around 67 years, and most of the patient had a good performance status, and majority of the patient had a progressed or a lapsed after chemo, and there were also a subgroup of patients which were received prior immunotherapy, and the number of prior lines of treatment were usually 1 or 2. Patients were having a lot of patients were having a visceral mets. The other factors were the HB level, tumor location, and a creatinine clearance rate. So coming on to the when this dose was dafitinib was used, the PFS was around 5.5 months with the overall survival of around 11.8 months, which has been recently updated to around 13.8 months. So confirmed overall response rate with this drug dafitinib was around 40%, and the median duration of response was 55.9 months. And out of that, the 31% of responders had a duration of response more than 1 year, and the median PFS already said was around 5.252 months, and a median overall survival of 11.3 months. 12 months and 24 months survival rates were 49% and 31% respectively. And the most common side effect was central serous retinopathy that occurred in around 27% of patients. The other drugs which can be used are the antibody drug conjugates. There are two basically antibody drug conjugates. One is enfortumab vedotin and the other is sacituzumab govitecan. The enfortumab vedotin is a fully humanized body. It targets basically Nectin-4, a transmembrane cell adhesion molecule, which is highly expressed in metastatic urothelial cancer. And the payload is a MMAE, which is a microtubule disrupting agent. This all drug got a accelerated FDA approval. And the other is a sacituzumab govitecan, which is again a humanized RS7 antibodies. Its target TROP-T, which is basically an epithelial surface antigen that is highly expressed in urothelial cancer, and uses as a SN38, which is the active metabolite irinotecan, as a payload. Again, this drug got a accelerated FDA approval. So we first will discuss with the sacituzumab govitecan. The approval was based on Trophy U01 study. So it was a single-arm open-label phase 2 trial. The patients, baseline population were locally advanced or metastatic urothelial cancer. There were basically three cohorts. The first cohorts were the patients who have progressive disease after platinum and anti-PD-L1 therapy. And the cohort 2 was patients who are platinum ineligible. and they had a PD after anti-PD-L1 therapy. And the third cohorts were the patients who are having progressive disease of platinum, and no prior anti-PD-L1 therapy was taken. The patients were randomized to the initial cohorts were randomized to drug of sacituzumab govitecan 10 milligram per kg on day 1 and 8 of 21 cycle, and these drugs were given until any PD or any unacceptable toxicity. The primary endpoints were overall response rate, secondary endpoints were safety, duration of response, PFS, and OS. So when we see the results, we can see the confirmed overall response rate was seen in 31% of patients, with a CR in 6% and a partial response in 25%. And with the median duration in months was 5.9 months, and the median time to tumor response was around 1.6 months. The blinded independent committee review, they assessed ORR, median DOR, and median TTR. They were all comparable to the investigator assessed outcomes. So in this waterfall plot, we can see, as we can see, there is around 76% decrease in the tumor size with this drug sacituzumab govitecan. So then this drug again was still is being studied. This drug is again studied in a phase 3 trial. Again, the patients who are having locally advanced metastatic urinary bladder cancer, they progressed of either a platinum-based therapy or immune checkpoint inhibitor. These drugs, the patients are being randomized to this drug and a treatment of physician choice, which could includes a chemotherapy. The primary aim of this trial is overall survival, and the secondary endpoints again PFS, overall response rate, and the duration of response. The results are still awaited. So the other antibody drug conjugate, which is being used, or it's enfortumab vedotin. This patient again, the basis of this drug was phase 2 trial. So in the baseline population, the patients were having locally advanced or metastatic urothelial carcinoma, or who had undergone previous PD-L1 treatment, and there is should be no grade 2 sensory motor neuropathy or any CNS mets or uncontrolled diabetes. There are basically two cohorts. The cohort 1 included the patient who have received prior PD-L1 inhibitor therapy and a platinum-based therapy. The cohort 2 included patients which have received a prior PD-L1 inhibitor therapy, but they have not received any platinums. A reason could be either could be platinum ineligible. The dose was used was 1.25 milligram per kg on day 1, 8, 15 of each 28-day cycles. The primary endpoint was a overall response rate, and secondary endpoints were PFS, OS, and a safety. So in the cohort 1, as we can see, the confirmed overall response rate were around 55%. There were 40 patients who had 40% had a partial response, but the main thing is that there was again a tumor shrinkage, which was seen in 84% of patients from the baseline. And if we see the cohort 2, the patients who had only received the anti-PD-L1 therapy and or were cisplatin eligible, or they received don't receive any platinums. So coming to the this cohort 2 population, again the median age was around 75. Majority were males and having good PS. The other factors were the renal function based on creatinine clearance, the primary tumor location. Either the patient received a first-line PD-L1 or a PD-L1 therapy. And if you see the overall response rate, it was around 52% in the this study population, and the confirmed CR was around 20%, and the confirmed PR was around 31%. So if you see the size in the tumor, change in the size of the tumor measurements in this waterfall plot, we can see again there was a 88% of accessible patient, they had a decrease in the tumor measurements from the baseline. And the duration of response was around 10.9 months in this subgroup of the patients. So on the basis, there was a phase 3 trial which again, they studied this drug. It was compared with the investigator choice of chemotherapy. The patient who were the baseline population were a happy patient having locally advanced or metastatic histology, either previously treated with the platinum containing chemotherapy, or they have relapsed after immunotherapy. The primary endpoint was with the OS, and the secondary endpoints were the PFS, the disease control rate, and the overall response rate and the safety. Again, the median age was around 68 in the both the population. Majority of the population were belong to Europe, and the patient were having good performance status. The Belmont risk score, most of the patient has this risk score less. This risk score is basically based on the patient performance status, the presence of liver mets, and the hemoglobin level. The other the factors were the liver mets and a prior line of a systemic therapy. So if we can see the primary endpoint overall survival, it was in the around 12.88 months in the enfortumab vedotin group compared to the 8.97 in the chemotherapy group. And the interim analysis, it met its primary endpoint. The overall survival was significantly increased with the enfortumab vedotin. And the most of the in the subgroups, the overall survival favored, but except the women. The secondary endpoints or like PFS. The PFS was median PFS was 5.5 in 5 months in this antibody drug conjugate group compared to the 3.71 in the chemotherapy group with a hazard ratio of 0.62. And if you see the confirmed overall response rate, they were also more in the antibody drug conjugate group, which are around 40.6% compared to the 17.9%, which is statistically significant. So if we use again these drugs, we should know how to manage the side effects profile. So if we are using enfortumab vedotin, if you experience peripheral neuropathy, it generally resolved and or it remains at a grade 1. Patient can have a risk of hyperglycemia, so we should monitor blood glucose levels. And if any rash is anticipated, it could be a maculopapular or diffuse rash. We should manage it with topical steroid antihistamines as well as dose reduction or delays. Rarely, some cases, systemic corticosteroids may be used. So if we consider side effects of the secukinumab govitecan, if the patient is having neutropenia, you can consider using growth factor support or either a dose reductions or a dose can be held. For the diarrhea, you should educate the patient and with the hydration with the electrolytes, and either antidiarrheal medication with the supportive care can be included. So as we have already discussed the treatment of cisplatin eligible and the ineligible population, the role of immunotherapy, but definitely if the patient has progressed on immunotherapy, the drug which can be used is one is the FGRF inhibitor. The results are better shown even if the patient has received platinum based chemotherapy and the drug is dafitinib. And the other antibody drug conjugates like enfortumab and secukinumab govitecan, they both can be used even if the patient had received anti-PD-1 and PD-L1 therapy or even a platinum-based chemotherapy. Thank you.
Thank you, Dr. Nadeep. And I think so in the interest of time, we'll be progressing for the next session. And the next session is by Dr. Piyush Mehta for the optimal first-line treatment for patient with advanced renal cell carcinoma. So I'll be sharing your slide, Dr. Piyush.
Yes, thank you. So good evening, everyone. So I'm going to discuss about the first line treatment for patients with advanced RCC. So this is an example, a 40-year-old man with clear cell RCC. Patient initially received nephrectomy, but he experienced recurrent disease to lung 9 months after surgery. And the lab test showed low hemoglobin, normal absolute neutrophil count, normal platelet, normal calcium, and Karnofsky performance scale 80%. Next slide. Next slide. So this is a NCCN guidelines, which shows we can see the first line therapy for the clear cell histology. That is in favorable risk, preferred regimens, they are axitinib with pembrolizumab, and another one is cabozantinib with nivolumab, lenvatinib with pembrolizumab, pazopanib, sunitinib. And in poor or intermediate risk subgroup, axitinib with pembrolizumab is category 1, along with cabozantinib and nivolumab, nivo-EP, lenvatinib, and pembrolizumab, and single drug cabozantinib. So these are the first line treatment for clear cell histology. Other recommended options, treatment options are axitinib with avelumab, nivolumab with epilumab in favorable subgroup, and cabozantinib, which is category 2B, and another is in poor or intermediate is axitinib with avelumab. Next. Next slide. So this is a stage for staging. It's IMDC prognostic, which include the hemoglobin. Previous slide, which includes the time from initial diagnosis to treatment, less than 1 year, then score 1. Karnofsky performance scored less than 80, then 1. Low hemoglobin, that is less than low limit of normal, high count and high neutrophil count, that was given 1 point. And prognostic risk group, a favorable risk, no prognostic factors. In intermediate group, 1 or 2 prognostic factors, and in poor risk, 3 or more than 3 to 6. So 75 to 80% of the patient with metastatic RCC, they fall into the poor or intermediate risk category. Next slide. Favorable is with 0 risk factor, intermediate 1 to 2, and poor is with 3 or more than 3. And we can see the overall survival, and it is maximum in those with a favorable. We can see that at 48 months, there is around 75, around the fall is this. In favorable, the x-axis is showing the months since therapy initiation, and on the y-axis is overall survival. We can see that as the risk factor increases, the overall survival that decreases with the time. Next slide. So the treatment options for intermediate or poor risk. So there's a checkmate 214, in which nivolumab with ipilimumab that was compared with sunitinib for untreated advanced RCC. We can see that in nivo-EP group, the median overall survival that was 48.1, and in sunitinib it was 26.6 with hazard ratio of 0.65. And so the patient subgroup which was taken, that was intermediate or poor risk category patients. They were enrolled in this study. Next slide. So in favorable risk, we can see that the line they merge, and still the median overall survival that is not reached, and we can see that that is almost similar. So it has more, it is indicated more in patients with intermediate or poor risk category. Next, next slide. Next slide. Oh, sorry, back, please. So keynote 4 to 6 for first line pembrolizumab with axitinib versus sunitinib in advanced or metastatic RCC. So in this, all risk patients, they were included, and we can see that with the median overall survival with a combination of pembrolizumab and axitinib is 45.7, and sunitinib with it is 40.1 with hazard ratio of 0.73, and p-value, significant p-value less than 0.001. Next slide. So this is in the intermediate or poor risk, keynote 4 to 6. Pembrolizumab with axitinib, median overall survival not reached, and with sunitinib it is 28.8 with significant p-value of 0.0001 and hazard ratio of 0.63. Next slide. So first line pembrolizumab with axitinib versus sunitinib with advanced or metastatic RCC. In favorable risk, we have seen that the combination, the events were 26 that were more in combination arm compared to sunitinib arm. With the p-value is not significant. They were almost similar in the favorable risk subgroup. Next. And in then checkmate 9ER, it's first line nivolumab with cabozantinib versus sunitinib in advanced or metastatic RCC. All risk in all risk combined, the median OS that is not reached in nivo and cabozantinib arm, and with sunitinib it is 29.5 with a hazard ratio of 0.6 and p-value of 0.0034. Significant reduction. So, next slide. So similar in intermediate risk, we can see that the median overall median OS is not yet reached, and while in the poor risk subgroup, it is 11.2 in sunitinib arm, while it's not reached in the nivolumab and cabozantinib. But we can see the difference in poor risk. That is definitely we can see as per graph that is more in the poor risk as compared to the intermediate risk population. Next. Checkmate 9ER. So it's a first line nivolumab cabozantinib in favorable risk. We can see that it is not reached, but the graphs they are merging. So it is almost similar as per this, and with a hazard ratio of 0.94. Next slide. So clear in the clear study, the first line lenvatinib with pembrolizumab or versus everolimus with or everolimus versus sunitinib in advanced RCC. So we can see that median overall survival is not yet reached, and but we can see we have taken all the risk patient in this and median follow-up was 27 months. And with lenvatinib with pembrolizumab versus sunitinib, the hazard ratio is 0.6 and p-value of 0.005. And with lenvatinib versus lenvatinib plus everolimus versus sunitinib, the hazard ratio is 1.15. So we can see that the median OS is not yet reached. We can also see the benefit of the combination of lenvatinib with pembrolizumab, as we can see in this graph. Next slide. So this is a cross-trial comparison of overall survival in intention to treat population. We can see that with checkmate 214 nivo AP, the overall survival, if you see, it's 83%, and with pembro axitinib, it's 90%, 86% with the experimental of in experimental arm in nivolumab and cabozantinib, and with pembro and lenvatinib it is 91%, and at 24 months it is 71% with nivo AP, it's 74% with pembrolizumab axitinib, 72% with nivo cabozantinib, and with pembro and lenvatinib it is 79%, almost similar. Next slide. So cross-trial comparison of response and intention to treat. We can see the overall response rate that is maximum in this pembrolizumab with lenvatinib arm in the clear study, and checkmate 9ER nivo AP 55%, pembrolizumab with axitinib that is 60%, and with nivo AP it's 39%, and the progressive disease that is 18% in nivo AP arm, 11% in pembrolizumab and axitinib, and 6% in nivo cabozantinib, and 5% in pembrolizumab and lenvatinib. Next slide. So these are the various trials. We can see the combination of immunotherapy with TKIs. So in checkmate, there is immunotherapy nivo and AP, and we can see the median overall survival, and overall survival at 12 months is 83 versus 78%, and its landmark overall survival at 24 months 71% compared to 61% in the another arm in sunitinib arm, and median PFS of 12.2 versus 12.3, it's almost similar, an overall response rate of 39, and complete response of 11%. In keynote 4 to 6, exitinib with pembrolizumab, we can see the overall survival 90% versus 79%, and 24 months it's 74%, with median PFS of 15.7 months, and overall response rate of 60% with complete response in 10%. And median follow-up was still 42 months, 43. Then in checkmate 9ER, 86% OS at 12 and 72 at 24. Median PFS 17 compared to 8.3 in the another arm, and overall response rate of 55 with complete response of in 9%. So in the clear study, we can see that overall survival that is 90%, and at 24 it is 79%, and with overall response rate of 71% and complete response in 16% of the patients. Next slide. So in the same patient which we have discussed, patient initially received nephrectomy but experienced recurrence, and we have already discussed the blood reports: low hemoglobin, low ANC, normal calcium, normal platelet. PFS Karnofsky performance is 80%. Next slide. So patient was started on a clinical trial of pembrolizumab with exitinib, and he had near complete resolution of the lung metastasis at first scan. Pembrolizumab was discontinued at 2 years, and exitinib was discontinued at 3.5 years. So response maintained to date at 4 years. So the patient asked that how long will my cancer stay controlled? So the next study will explain this. Next slide. So this is a treatment-free survival in checkmate 214. You can see the living treatment-free after a metastatic diagnosis. So in this graph, in checkmate 214 in Nivo AP, we can see patients, percentage of patient who are, we can see in the dark purple, who are remaining on treatment without any grade more than or equal to grade 2 treatment-related adverse event. We can see, and then we can see the population survival after subsequent treatment and treatment-free, alive and without any adverse events. So we can see that the patients who are treatment-free and who are alive and without adverse events, that we can see in this blue, we can see that percentage that obviously that decreases with time. And at around 24 months, we can see that approximately in around 30 to 40% of the patients, they are living without any adverse events. The next slide. So conclusion, the immunotherapy and TK combination that yield the best combination of upfront overall response rate, PFS, and long-term benefit to date. And for favorable risk patient, some can be observed or started on single agent VEGF TKI, and good toxicity management ensure responding patients can stay on active therapy for a longer time. That's it. Thank you.
Thank you, Dr. Piyush. I would like to invite Dr. Priyanshu for the next talk. Dr. Priyanshu.
Dr. Praveen is the next speaker. Dr. Praveen Jain will be there.
Hi, Priyanshu.
Hi, sir. How are you?
I'm good. And thanks for giving me this opportunity. 1 second, let me share my slides. I hope my slides are visible and I'm audible.
Yes,
sir.
Okay. 1 second. Yeah. So thanks, Priyanshu, for giving me this opportunity. So today's talk, which has been given to me, is the optimal treatment for patients with progressive RCC after 1 or more previous lines of therapy. So as Dr. Piyush explained all the options in first line. So what we are facing these days, or the circumstances which are which are coming to us is that the patient has already received first line immunotherapies, and the previous options which we were having in the subsequent lines, they were all after the VEGF TKI therapy only. So now we have a situation where we have to select our subsequent line therapies also on the basis of the option which was chosen in the first line. And we have a lot of options in first line, only VEGF directed therapy, then VEGF directed therapy plus IO combination, then IO combination. So we have to select our subsequent line therapy according to the option which was chosen in the first line. So we will be discussing about all these options in the subsequent slides. And these are the options which are recommended by the NCCN guidelines 2022. And the preferred regime in the subsequent therapy is cabozantinib, then lenvatinib plus everolimus, then nivolumab, and then axitinib. These are the 4 preferred agents, and we will be discussing our choice of therapy depending on what we have chosen in the first line. There are other options also, like those options which were in the first line which have not been used in the first line, like IO combination along with VEGF inhibitors. So they can be used in subsequent line also if they have not been chosen in the first line. So first of all, let us go towards clinical trial data, which is supportive of sequencing VEGF directed therapy before the era of IO combinations. So these are those patients where the first line therapy was VEGF directed therapy. And there was this phase 3 Meteor trial which tried cabozantinib versus everolimus. And everolimus is a universal comparator arm for all these trials of VEGF directed therapy or IO single agent in subsequent line, because everolimus was the standard of care at that time. So here the patients were randomized into cabozantinib versus everolimus in 1:1 fashion, and we can see over here that the median overall survival with cabozantinib was 21.4 months, and everolimus it was 17.1 months, and the p-value was 0.0002, which was highly significant. And we can see over here in the Kaplan-Meier graph also that the graph separated early on and they remained separated throughout. And overall response rate along with cabozantinib was 17% vis-a-vis 3% with everolimus alone. And probably the reason behind this is that there are some of these patients who are treated with VEGF directed therapy who have got MET aberrations, and on those MET aberrations like MET amplification or MET mutation, so cabozantinib acts better as compared to any other VEGF TKI or everolimus. So coming to another option, that was lenvatinib and everolimus. So it was a phase 2 trial, and it was a 3-arm trial where the patients were selected, randomized in 1:1:1 fashion into single agent lenvatinib, single agent everolimus, or the combination of both. So in single agent lenvatinib, the dose which was selected was 24 milligram per day, and everolimus it was 10 milligram per day. And lenvatinib plus everolimus, the dose was 5 milligram of everolimus along with 18 milligram of lenvatinib. So with this and the primary analysis which was done in this particular trial was lenvatinib versus everolimus and lenvatinib plus everolimus versus everolimus. So the comparator arm or the standard of care arm was again everolimus in this trial. And we can see over here that the hazard ratio with lenvatinib plus everolimus was 0.51. That means that there was 49% relative risk reduction in the overall survival in favor of lenvatinib plus everolimus. Again, coming to lenvatinib versus everolimus, the hazard ratio was 0.68, and there was 32% relative risk reduction in favor of lenvatinib. And if we see the overall response rates again, so it has got the best overall response rate, best overall survival, like overall response rate with lenvatinib plus everolimus was 43% versus 6% with everolimus alone. So this regime, it had become the standard of care after VEGF directed treatment or first line TKI IO based combination. But now coming to those trials where they have assessed the clinical activity of VEGF directed treatment following checkpoint inhibitor therapy in the front line. So this is the practical option for us which we come across most of the times. So again, this was a phase 2 trial. So as we had seen in the previous slide, that lenvatinib plus everolimus, it had become the standard of care. But there were almost 70% dose reductions in lenvatinib plus everolimus combination. So it was effective, but it was toxic also. So this trial was done with an intent to see whether the dose reduction of lenvatinib from 18 milligram to 14 milligram, does it have any like inferiority, or it is non-inferior to 18 milligram per day. And in this particular trial, so the prior IO agent usage was also allowed, and we can see over here that 26% of the patient, they received previous IO therapy, and 81% of the patient, they were IMDC intermediate or poor risk status. So if we see the overall response rate at week 24, so it was numerically better with the 18 milligram, but there was no statistically significant difference in between the two, and they were almost equal. It was the 14 milligram was non-inferior to 18 milligram. If we see the overall survival, so again, if we see in intention to treat population, so lenvatinib 18 milligram plus everolimus, it was the curve separated early on, but this was again statistically insignificant improvement in favor of 18 milligram. If we see particularly in those patients who had received prior IO as the frontline therapy, so again the hazard ratio was 1.28, and the confidence interval were crossing the line of infinity. So the thing was that it was definitely 14 milligram was not superior or to 18 milligram. So 18 milligram remained standard of care after this trial. And if you want to use lenvatinib plus everolimus, so the dosage has to be 18 milligram plus 5 milligram of everolimus on a daily basis. So coming to another trial, TiVo3, it was a phase 3 trial where the tivozanib was compared with sorafenib in advanced RCC after VEGF TKI therapy. In this trial also, almost 1/4 of the patient, they had received immune checkpoint inhibitor plus TKI in the first line. And we can see over here that the overall response rate with tivozanib was 18% vis-a-vis 8% with sorafenib. Again, it is a valid option in those with prior IO therapy. So coming to axitinib. So axitinib, we have to understand there are two things which we want to discuss in axitinib. So one is regarding the post-IO usage of axitinib, and another concept is dose individualization with axitinib. So the previous trial, they had studied 5 milligram twice a day fixed dosage. And this phase 2 trial, and there was another phase 2 trial by the name of, I think, trial 1046 or something. So they used these individualized dosing for RCC after IO therapy. And most of the patients, they had received IO in the as a first line agent. And what they did was that they started with the axitinib dosage of 5 milligram twice a day. And if in the initial 3 to 4 weeks, the patient did not have any dose limiting toxicity, so they they titrated the dose in 1 milligram increment to 10 milligram twice a day and on a fortnightly basis. So the maximum dosage which a patient could have received was 10 milligram twice a day. And we can see over here that the median PFS was 8.8 months. And in another trial, which was trial 1046, what they had done was that after 3 to 4 weeks of stabilizing dose of axitinib, so they had randomized the patient into 2 arms. So one was the patient who had increased the dose increment, and the other was where the dose increment were in the placebo form. And what they had observed was that the overall response rate had gone up from close to 35% to 54%, and there was almost 20% increment in the overall response rate with individualized dosing and incremental dosing of axitinib. So this is something which we have to understand that axitinib, if we are using and if there is no dose limiting toxicity, probably we should increase the dosage. of exitinib, and we should take it towards 10 milligram twice a day. So coming to another concept of using immunotherapy agents after failure of another immunotherapy agents. So there are three trials with that. So one is the phase 2 keynote 146 or public study 1111. So where lenvatinib plus pembrolizumab has been given after progression on previous IO therapy, and it was an open label phase 1B or 2 study, and they had in total selected 145 patients, and they had selected patients who had not received any systemic treatment for RCC, which were 22 in number, but they had also taken those patients who had received previous IO treatment for RCC, and the number of patients were 104. And these patients who had progressed on IO previous IO treatment, they were given lenvatinib plus pembrolizumab, and the dose of lenvatinib was 20 milligram per day, and pembrolizumab it was 200 milligram Q3 weekly. So we can see over here that the overall response rate in IO naive patient, it was 41.2%. But if we see in those patients where there was previous IO which was given, so it was 55.8%. So I cannot tell you the reason for this because I couldn't see the complete paper, and they have not discussed regarding the explanation of why this has happened. So probably because in IO naive, so the number of patients, they were quite less, and it was 17 only, and probably it was by chance they had observed that the overall response rate was better in those who had received IO in the first line. So if we see the partial response, again, incredible 62.5% of the patient, they had partial response, and 29.8% of the patient, they had stable disease. And we can see over here that only 7.6% of the patient, they were having either progressive disease or not evaluable patient. And the median PFS with this regime was 12.2 months, which was again a tremendous improvement in the median PFS. You can see over here that the median OS is not reached till now after a median follow-up of close to 12.2 months. So now coming to novel targets in RCC post immunotherapy progression. So in this particular subset, there are clinical trial of nivolumab plus cabozantinib also, which has shown good response rates. Again, there is a trial on nivolumab failure. So these people have tried nivolumab plus ipilimumab, and there also the response rates, they increased, and the PFS also was better. So now coming to belzutifan. So belzutifan, it is a oral small molecule HIF hypoxia inducible factor 2 alpha inhibitor, which has got anti-tumor activity in clear cell RCC. And this was a dose escalation expansion study. And in this, they had selected the patient with clear cell RCC who had received more than equal to one previous therapy. And these patients received belzutifan 120 milligram once a day until progression or unacceptable toxicity. So we can see over here that the overall response rate with belzutifan was 25%, and disease control rate was 80%. And the PFS was 14.5 months with belzutifan, which is again the best PFS which we have achieved in this particular line. I think only lenvatinib plus everolimus had reached this PFS of close to 14 months. But we have to see this agent in subsequent phase 2, phase 3 trial. And this is not a kind of drug which is very, very toxic. We can see over here that the grade 4 adverse event were observed only in 4% of the patients, and grade 5 adverse event were reported in the 7% of the patient. And the main adverse events were the anemia and hypoxia. So these are the clinical trials which are recently closed or actively recruiting. So one is the phase 3 trial of belzutifan versus everolimus in the previously treated subset. Then is the contact 3 trial where atezo plus cabozantinib is being used, being tried versus cabozantinib in the second line clear cell RCC or non-clear clear cell RCC. Here also these patients had received IO as a frontline treatment. Then TiNivo trial where nivolumab and tivozanib versus tivozanib is being tried, where already the patient has received more than one line of therapy. So after all these discussion, these are our therapies which can be used as a subsequent line. So one is nivolumab, and another is nivolumab plus ipilimumab, then cabozantinib, then lenvatinib plus everolimus, then axitinib. So these are all our options. So these are the comparison among the most used option. One is the axitinib. We can see over here that the overall response rate is best with lenvatinib and everolimus, and the patient population was TKI refractory 100%, and we can see over here that the PFS was 12.8 months, which was the highest among these four agents, and the overall survival was again 25.5 months. But we can see over here that there were 71% of the patient who had some dose reduction, and 24% of the patient had discontinuation, dose discontinuations, and the grade 3-4 toxicity were observed in almost 71%. So this is something which we have to look for in whenever we are selecting for lenvatinib everolimus. So these are the median PFS analysis, and we can see over here again the curves were the best for lenvatinib everolimus as compared to other. So with this, I would like to end my talk. Back to organizers. Thank you.
Thank you, sir. And just one question, sir. What is your preferred choice of therapy post IO in second line?
So Priyanshu, see, first of all, I have not used IO in first line till now. So
Okay.
because these therapies are still not approved in India, because of which these people, they are not getting assistance, and it is very, very difficult to pay out of their own pocket such a heavy and costly drugs. So but if we see the data, so my first choice in a very fit individual will be lenvatinib plus everolimus. And if a patient is out of a panel thing, and the patient is tolerating, like if the patient was started on probably pembrolizumab, or patient was started on nivolumab in the first line, so then I will definitely try to switch to second option of IO plus some TKI combination. Like if initially only nivolumab was started, I would be keen in starting nivolumab plus cabozantinib, and if patient was started on pembrolizumab, then I'll be keen in using pembro plus lenvatinib. But and another thing is that if we can do a biopsy and we can just try to look for MET aberrations, then cabozantinib alone is a good option.
Okay, thank you, sir. Thank you. So next, I would like to. Yeah, go on, Pooja.
Can I go ahead?
Yeah, sure.
So our next speaker is Dr. Manish Sharma, sir. He is a consultant, head of unit medical oncology from RGCI Delhi. Over to you, sir, for your presentation.
I think so. I have the slide. I'll be sharing it. Dr. Manish, you are muted.
So, Dr. Priyanshu, I have slides and
Okay, sir. Fine. Okay, sir. Go ahead.
So, I would first like to congratulate Dr. Priyanshu that you have done a wonderful job today and such a great academic feast.
Thank you, sir.
Simultaneously, I think you have covered most of the recent topics with this disease, and congratulations, Dr. Praveen also did a very wonderful job. So my job today is to describe the side effects of androgen deprivation therapy. So this topic has been given to me by very dear friend Priyanshu. I think my screen is not moving. Oh, sorry. Oh, it is moving now?
Yes, sir, it is moving.
Okay. So I think so this is indeed a very, very important topic. We have been discussing about progression-free survival, overall survival, and this and that. But simultaneously, we should also recognize the side effects of this andropause that happens in males once we use this combined androgen blockade. So this is the historical perspective of using these androgen blockades, ADT, in CS species. And you can clearly see here that this was a paper which was published in 1941, and then repeatedly this image has been seen by in another journals as well. You can clearly see that once you subject these patients to androgen deprivation therapy, there is a significant amount of bone losses, increased alkaline phosphatase just within 50 days of the starting of the treatment, and decreased level of acid phosphatase. Well, indeed, this is a very, very important therapy for our patients who have CSPC or even in the CRPC stage. So this is the main pathway of CSPC. We all know, and the audience here knows it very well, that the prostate cancers from the stage they are diagnosed till the time they are in the CRPC stage, they are dependent upon testosterone. GnRH is produced from hypothalamus, pituitary gets a signal, and then the FSH and LH are produced. Then the testosterone is produced by the Leydig cells. These then further leads to the production of testosterone and hence help in the so we have different blocks receptor level also, which is AR receptor antagonist. We have been using enzalutamide, flutamide, nilotamide, and now we have darolutamide also in our armamentarium. So this is the mechanism of action, and we'll not go into the detail. There is pulsatile secretion of GnRH from the hypothalamus, and once you use agonist, GnRH agonist, continuous use of the GnRH suppression of LH and leading to the testosterone suppression. But once you are using GnRH, what are the considerations which we have when we subject our patients to complete androgen blockade or ADT? So mode of administration is very, very important. Efficacy is of course very, very important, and then safety analysis and adverse events. As we know that this treatment is associated with bone loss and cardiovascular events. So this is a trial in which the degarelix, which is an antagonist molecule, was compared against leuprolide, which is agonist. And there is this, the patients, they were adenocarcinoma any stage with indication for having ADT. And this trial proved that using degarelix was non-inferior to leuprolide at maintaining low doses of testosterone level. And similarly, this is another study, which is HERO study. And you can see here the clinical trial design in which relugolix, which is a GnRH antagonist, was directly compared to leuprolide 11.25 milligram or 22.5 milligram directly monthly. And the key efficacy outcome was the maintaining the castrate level of the testosterone. And this trial also found that the similar result, that the relugolix was non-inferior and in fact was superior to leuprolide in maintaining the castrate level of testosterone in prostate cancer patients. So coming on to the safety and adverse events, which are very, very important when we choose our drug. In this HERO study, we can clearly see here that MACE, that is major adverse cardiac events, they were clearly less as compared to the leuprolide arm. So you can see here those patients who had any kind of MACE or who had no history of MACE or had a history of major adverse cardiovascular event earlier also. You can clearly see here the numbers, they are pretty low as compared to that in the leuprolide arm. So 3.6 here and 17.8% here in the leuprolide arm. Similarly, if you see here, if you see hypertension is 7.9% here in the antagonist arm as compared to 11.7% in the agonist arm. Although the all grade and grade 3 and 4 adverse events, they were almost similar, but the cardiovascular events, they were lesser in antagonist arm. What are the other risk factors associated with ADT? So these are clearly linked to the andropause which happened in males, stoppage of testosterone. So it occurs, and the hot flashes, osteoporosis. So osteoporosis, you can see that 1 to 3% is the annual risk of fracture once these patients are even on calcium and vitamin D supplements. Fatigue, metabolic syndrome leading to the weight gain, erectile dysfunctions, cardiovascular disease. Although the data is unresolved and still conflicting in the meta-analysis and observational studies, but yes, there are the chances of primary and secondary cardiovascular events. And similarly, thromboembolic phenomena are also very common. So you can see here that this is common, these are all common, but the risk of cardiovascular events and thromboembolic disease, this remains still unresolved, whether the antagonist versus agonist increases or decreases the risk of cardiovascular event. But one thing is clear, that once the patients, they are testosterone deprived, they have enough of thromboembolic events and the cardiovascular events. These are the metabolic consequences: weight loss, dyslipidemia, loss of lean muscle weight, and the strategies are to refer timely to the dietitian, assess the risk of fall in the elderly and frail patients so as to prevent the fall and fracture, and risk adapted diabetes screening and management as per the American Diabetes Association guidelines. Skeletal related events are also common with use of ADT. The sex steroids, they help in the proliferation of osteoblasts, they help in the bone mineralization, and they help and the reduction and the stopping of the testosterone results in the bone demineralization and increased fracture risk. And hence there is decrease in bone mineral density. Annually, if you see, there is 2 to 8% loss of BMD in lumbar spine and 1.8 to 6.5% in the femoral neck if you measure the bone mineral densities in these patients. And these patients are certainly at the risk of increased fracture because of fall also. We discussed this, the ADT, it leads to the decreased fibroblast maturation, leading to the muscle degeneration. It leads to the dysregulation of various anabolic pathways, and hence the lean body mass decreases. There is increase in fat mass and decreased strength of the muscle and endurance within 6 months of starting of treatment. So these all things are pretty clear, and this is the strategy and recommendation for the patients: how to manage them, how to screen them, do a DEXA scan, look for osteopenia, osteoporosis, and repeat them every 1 to 2 years. Take blood tests of calcium, creatinine, and 24-hydroxyvitamin D, supplement wherever necessary. And most of the patients, they are in the age group, require calcium and vitamin D supplement very well. Strong recommendation should be for smoking cessation, which leads to the loss of bone mass. Similarly, alcohol should be done in moderation, and weight-bearing exercises, they are strongly recommended for these patients. So how to prevent muscle health? You need to have supervised resistant and aerobic exercises 3 to 5 times per week for 12 to 24 weeks since the time you are on treatment. Lifestyle modifications, calcium and vitamin D, they are must. Then smoking cessation, decreased alcohol intake. Similarly, risk assessment with the help of DEXA scans within 6 months of initiation of ADT, and at least 2 years every 2 years till the time patient is on treatment. And on the assessment of the risk, you should initiate the patient on denosumab or bisphosphonates 3 monthly. So what about the cardiovascular risk assessment? Is it needed? Does the GnRH analogs, they are more they cause more of cardiovascular problems, or GnRH antagonist causes more of cardiovascular problems? So there is clear indication that the cardiovascular health is not taken care of by many physicians during their practice. And there is a clear-cut data from US which shows that more than 30% of patients who are on ADT, they do not receive a comprehensive cardiovascular assessment. And hence, the AHA, ACS, and AUA strongly recommended in 2010 that these patients should be regularly monitored on blood pressure, lipid profile, and blood glucose. And NCCN 2021 guidelines also recommends for screening and intervention to treat diabetes and cardiovascular disease for these patients. And similarly, in 2010, you see the FDA, it has issued a notification that the GnRH analogs, they should add a new safety signal for their prescriptions that these drugs causes cardiovascular mortality, increased diabetes, and metabolic complications. And hence the notification was based on the FDA review of various published studies. This is the package insert of Duprolide, which clearly reads about the cardiovascular risk factors, increased risk of developing myocardial infarctions, sudden cardiac death, stroke, which are at for those men who are on GnRH agonist treatment for their complete androgen blockade or androgen blockade treatment.
Sir, I would request you to finish it in the next 2 to 3 minutes, please.
Dr. Priyanshu, I have not been given even 8 minutes also.
Sir, we are sorry, we are running late. We can have 5 minutes more probably.
Okay, so I'll try to wrap it.
Yes, sir. Thank you, sir.
So you see that there is an inconsistent relationship between ADT and cardiovascular death. So some of the observational studies. So I will So this is important that the meta-analysis of observational studies, they have reported the association between ADT and greater risk of cardiovascular death and events. There is consistent association for GnRH agonist and cardiovascular events, but there is mixed association of GnRH antagonist and cardiovascular events. So there is clear indication that GnRH agonist causes them, but the association it is mixed for GnRH antagonist and cardiovascular events. So RCTs, they may have underestimated the CVS risk due to selection bias and crossover in control group. RCTs were designed and powered for cancer outcome, and they were insensitive for the assessment of cardiovascular outcome. And observational studies may overestimate the cardiovascular risk due to the confounding and outcome reporting biases. So there is, so I will quickly go through one of the randomized control trials. So randomized control trial, they are the best to give us the answer. One of the trial from the HERO study we discussed about relugolix, it stated that the major cardiovascular events, they are not increased if you use regulolix compared to the leuprolide. So here is a pronounced trial which looked at the cardiovascular safety of degarelix versus leuprolide. So I will not go into the detail. This was the randomized phase 3 control trial. The patients in the one arm received degarelix, and in the another arm, they received leuprolide every 3 months. So this is the patient characteristics. And if you come to the result of this clinical trial, you can see that the cardiovascular events, they were not significant in any of the subgroups. So neither in antagonist arm, neither in the agonist arm, this was statistically significant. You can see that p-value for all of them, whether first MI or first stroke or cardiovascular related death, they were statistically not significant. So I will wind up my talk and let's come to the conclusions. Difference in the mechanism of action amongst ADT are important and may have both treatment and adverse event experience. The identification and the management of adverse events are critical component of the management. These includes metabolic, musculoskeletal, cognitive, neuropsychiatric adverse events, as well as sexual dysfunctions. ADT-associated cardiovascular morbidity and mortality remains a risk, and it is still unresolved and it needs further studies. Difference between cardiovascular morbidity and risk profile in GnRH agonist and antagonist should be compared in head-to-head studies, as was done in pronounced trial, and careful attention should be made towards cardiovascular management in men receiving ADT and should reduce adverse events and improve outcome. For the patient receiving ADT, it is important to consider annual bone test, calcium, creatinine, vitamin D monitoring, smoking cessation, alcohol intake moderation, and weight bearing exercises. Thank you so much, Dr. Priyanshu. I hope I kept it in time.
Thank you, sir, and sorry for the inconvenience. So next, I would like to invite Dr. Kanika, who is an Associate Consultant in Max Super Specialty Hospital, Mohali, for the next talk.
Good evening, everyone, and thank you so much for giving me this opportunity. I will be sharing my PPT. So, is my PPT visible?
Not yet, ma'am. Yes, it's visible now. You can make it full screen. Yes, it's visible. You can make it full.
Okay. So, good evening. Today, I'll be talking about the systemic treatment intensification in metastatic hormone-sensitive prostate cancer. So, as we are listening to so many talks today, so now we are just flooded with treatment options on all the sites, and it's actually very difficult to make the appropriate treatment option for the patient and to actually guide them regarding all these options. So when we say hormone sensitive prostate cancer, so either it can be de novo, that the patient is already presenting upfront with a metastatic disease, or it can be seen in the patient who have previously received local therapy and now they are progressing to the hormone sensitive disease. So as per 2021 guidelines, now there are so many options that are approved for patient in HSPC. So there are various ADT, and along with ADT, you can use hormonal like abiraterone, apalutamide, and enzalutamide. And in chemotherapy, we have the options of docetaxel. And radiation part that we'll be discussing in the later seminar, that is the EBRT also in the metastatic disease patients who have a low volume disease. So when we are listing all these treatment options, so there are various prognostic subgroups that are that have divided the hormone sensitive patients into 3 subgroups. The first one with the patients who have a good prognosis, who are actually progressed after receiving the prior treatment. So prior local treatment they have received and now presented with a low volume disease. Then come the intermediate risk group. The patient have received prior therapy and now presenting in high volume disease, or they are presenting with a de novo low volume disease. And the poor prognosis patients who are presenting with a de novo high volume disease. So there are various trials, but the trials that lead to the path to all these agents were the Charted trial, the Stampede, the Latitude trials. So these were the landmark trials that actually led to the inclusion of all these agents into the hormone sensitive group. Earlier, only ADT were used until the patient progressed to the castration resistant stage. So now, when we say chemohormonal therapy, so there are in the docetaxel, there are actually the 3 trials that were done: the Charted trial, the Stampede, and the Getup trial. So Charted and the Stampede both show the overall survival benefit. So in the Charted, it was the docetaxel plus ADT versus ADT alone in the patients of hormone sensitive who have elevated PSA. So when we say the risk and the low volume and high volume disease, so as per the Charted trial, any patient who have a visceral metastasis and or more than 4 bony lesions with more than 1 lesion beyond the vertebral body or the pelvis, so they are termed as a high volume disease. Whereas in the Latitude trial, they have defined high risk as the patient who have more than 3 bony mets, visceral mets, and they have also included the Gleason score that is more than equal to 8. And frankly, in my practice also, I give an importance to Gleason score. So patients who present with a high Gleason score of 9 or maybe 10, so I would, ink towards the chemotherapy more than the oral agents in these patients. So when we see the Kaplan-Meier for Charted as well as the Stampede trial, so the docetaxel have shown a significant OS benefit of in both the trials, and in the Charted as well as the Stampede trial. And when we see on the basis of the high volume versus the low volume disease, then the benefit was even higher in the high volume disease. So as you can see, even the 51.2 months as compared to the 34.4 months in the ADT alone arm. So the difference is significantly higher in the high volume disease, whereas the benefit was still there in the low volume disease, but not as compared to the high volume. Whereas in the Stampede trial also, in the Stampede trial, they also showed the OS benefit, but when we compared the stratification based on the metastatic burden of the disease, there was not much difference between the high and low burden disease. So based on the meta-analysis that have included all the 3 patients, so docetaxel have significantly shown survival benefit in the HSPC group, and there was an overall absolute improvement in the overall survival of 9% at 4 years, and there was a 16% PFS benefit, and absolute improvement was there at 4 years. So then we come to the next agent, that is the abiraterone. So besides docetaxel, the agent that have shown OS benefit and that is most frequently used in the first line setting being the oral agent, the patient does not have to come to the OPD on the regular basis, and definitely the side effect profile. With docetaxel, it is not a very easy drug to tolerate, and patient also have a prolonged neutropenias are there, mucositis are there, and the treatment delays and nausea and all of that is included with the agent. So when we come to the abiraterone acetate, there were the 2 trials that were done, that is the Latitude trial that randomized a patient to abiraterone plus ADT versus placebo along with ADT. And as we have previously discussed, the high-risk criteria was a little bit different from as compared to the Charted trial, and they have included the Gleason score as one of the features to stratify patients. Whereas in the Stampede trial, as we know, there are now, I think, around 15 to 16 different arms for Stampede trial. So they have included newly diagnosed metastatic disease that was pelvic node positive or a high risk locally advanced with more than equal to 2 high risk features, that is Gleason higher, more than T3, T4 disease, and PSA more than 40. And also the patient who are relapsing after the local therapy with the high-risk features, like patients have a more PSA doubling time of less than 6 months, or metastatic or nodal relapse was there, or there was less than 12 months of total ADT, including the interval, that is without the treatment. So as can see in both the trials, the Latitude and the Stampede trials, they have shown that there was a decreased all-cause mortality was there for the combination therapy. And that has shown a significant benefit in the overall survival as well as the progression-free survival in the abiraterone arm. So when we compare docetaxel versus abiraterone, when the comparison is being done, so when we see the failure-free survival and the progression-free survival, there was definitely benefit towards the abiraterone arm as compared to the docetaxel arm, and all the evidence also favors and aims towards the abiraterone. Otherwise, as compared to the metastasis progression-free survival of if the patient have a symptomatic skeletal events was there, or a cause-specific survival, or as compared to the OS survival. So both the arms, they were comparable. So abiraterone and docetaxel, they both fare well when come to the OS benefit. So when, in my opinion, when choosing between docetaxel and abiraterone, so both drugs, they have shown an OS benefit. The abiraterone, they have a progression-free survival advantage over docetaxel. And again, the final choice when we choose between both the drugs, it depends on the availability, the cost of the therapy, side effect profile. If the patient is young, then definitely, and they have a high volume diseases there, high Gleason score is there. So I prefer to give docetaxel as compared to the abiraterone in the first line setting. And again, patient preference also. Now, so many patients, they want to have oral treatment as compared to IV chemotherapy. So then there are the newer agents that are available. That is the Titan trial that assess the role of apalutamide plus ADT in the HSPC group. So it's a phase 3 trial that have randomized patients of castrate sensitive prostate cancer. And they have actually randomized based on the ECOG performance status of 0 and 1, of prior ADT, whether it was received less than 6 months or less than 3 years for local disease, and Gleason score also. So they have divided, so apalutamide 240 mg per day with along with ADT or ADT alone. So the primary endpoint was again overall survival and the radiographic progression-free survival. So as we can see, at the follow-up of around 2 years, there was a benefit with apalutamide plus ADT as compared to the placebo. And there was a difference of around 20% in the radiological progression-free survival. And also there was a OS benefit was there in the apalutamide arm. Next, come to the other agent, that is the enzalutamide. So enzalutamide along with ADT versus placebo. So there were 2 trials, that is the ARCHES trial and the ENZAMET trial, that evaluated the role of enzalutamide in HSPC setting. And again, they have randomized based on the treatment gap between the previous therapy, whether the patient have received prior docetaxel or not. And again, they have also done a subgroup analysis, whether it's a high volume disease, visceral mets was there, or it's a low volume disease. So patient received enzalutamide 160 mg per day compared with placebo. So in the ARCHES trial, there was a benefit in the radiographic progression-free survival in the enzalutamide arm. It was not reached in the enzalutamide arm as compared to the 19 months in the placebo when we see PFS. And the overall survival, the survival data were immature, but it significantly links towards the PFS benefit. So even in the subgroup analysis, so first we are going to discuss the ENZAMET trial. So this has also shown the benefit, but when it was done in comparison with the patients who have received prior docetaxel, so the benefit was not that much in the patients who have received prior docetaxel, and also in the patients who have visceral mets and specifically liver mets. So the prognosis was not that good in the visceral mets arm, and the patients who are so the benefit was less as compared to the patient who have a low volume disease or who have not received the prior docetaxel. So, but in the ARCHES trial, when we have seen the subgroup analysis in the forest plot, so all the subgroup of the patient, they benefited with the addition of enzalutamide, whether it was age or whether it was the Gleason score based on, or whether it was just bone only or bone plus soft tissue, low volume, high volume, and the docetaxel. So all of the subgroups, they favor the enzalutamide as compared to ADT alone. So again, as we were discussing that in the ENZAMET trial, when we see that the patient who have received a docetaxel, so there was the graphs were overlapping, and there was no OS benefit seen in the subgroup. If the patient have not received docetaxel, so the graphs can be seen separating, and there was a benefit in these patients. Now, first, we have evolved from only ADT to the addition of the other agents like chemotherapy or hormonal therapy. And now we are going like to hit hard on the first attempt only. So now it's treatment intensification. So in this ASCO GU 2022, there was the Arison's trial that was presented, and that showed actually triplet in the therapy in the first line setting. So the patients were, it's a phase 3 trial that have included the patient of metastatic hormone sensitive prostate cancer. Patients were having a PS of 0 and 1, and they are the candidates for ADT and docetaxel. The patients who are eligible for these agents, they were randomized into 2 arms. The one who received docetaxel for 6 cycles along with darolutamide 600 mg twice daily, along with ADT, and the other arm include the placebo plus ADT and the same like a charted trial of 6 cycles. So the primary endpoint is overall survival, and the secondary, they have seen what was the time to progression to CRPC, that is the castration resistant stage, time to pain progression, time to first symptomatic skeletal event, when was that, and what was the time of initiation of subsequent systemic antineoplastic therapy. So when it was seen, so darolutamide, it significantly reduced the risk of death by around 32%. And there was a significant difference in the patients who received darolutamide along with docetaxel as compared to docetaxel alone arm. So even when we see the time to castration resistant phase also, so you can see that there was a huge gap between the two graphs. So the patient, they significantly fare better in the darolutamide arm, in which it was not reached the time to CRPC as compared to only 19.1 months in the docetaxel plus ADT arm. And also time to pain progression also was significantly better in the darolutamide arm. So when we see the adverse event between the two group, so it was comparable, and the number of grade 1 to 4 toxicities, it were comparable between the two arms. So again, the first slide that we discussed, that there are now so many options that are available. So how to choose between all these options, like quality of life, what is the quality of life of the patient, what will be the patient preferences, that all these factors must also be considered. So what are the potential decision-making factors in metastatic hormone-sensitive prostate cancer? So we can see the benefit in the trial endpoints like overall survival and the cancer-free survival. So both apalutamide, abiraterone, and docetaxel, they have shown OS benefit. What was the time to castration resistance, as was seen in the darolutamide arm, or what was the PSA, radiographic PSA, quality of life, and the disease characteristic. That is most important, that what when we are making the treatment decision for the first line setting, that what is exactly the disease volume and the risk, the Gleason score, whether there is visceral mets at the time of presentation, what was the timing of metastatic disease, whether it's a recurrent or a de novo setting. So all these factors, and obviously patient characteristics like age, performance status, comorbidities, because the adverse effect, the side effect profile is completely different of all the agents. So when we consider based on the overall survival parameters, so as we can see, the GETIC trial does not show much of the OS benefit, but both CHARTED and the STAMPEDE arm, they have shown a OS benefit in the docetaxel arm. Again, with the abiraterone, both LATITUDE and STAMPEDE, they have shown a OS benefit with abiraterone. Even the enzalutamide, apalutamide, so all of these agents, they have shown the OS benefit. So when we see the quality of life of these patients, so when we consider docetaxel, there is a slight dip in the quality of life in the first 9 months when the patient is receiving the treatment. But after the treatment is over, it is actually better than the ADT alone arm, beside the initial dip. When we see the abiraterone arm, it was again, the better from the initial start of the treatment. So if the patient PS is not good and the patient cannot tolerate docetaxel, it is better to start with abiraterone, because there was significant difference in the quality of life between abiraterone and the ATT. The apalutamide does not have a significant difference on the quality of life of the patient. And when we see enzalutamide, so again, that have not shown to affect so much of the patient quality of life based on the physical function or a cognitive or fatigue is there. So not much of a difference. Just with the enzalutamide, the incidence of seizures are high, and that has to be taken into account, and especially in patients who have received prior docetaxel. So the other things that are actually considered in the clinic is how many visits will be to the hospital, how often I have to come, how long will I need this treatment, because most of our patients, they are coming from the out of state and they are traveling for so many kilometers. So they're like, whether we have to travel frequently, like with docetaxel for the injection, you have to come, and even if the patient have a grade 3, grade 4 side effect, then they have to come before 3 weekly duration also. So whether it will be a pill or IV injection, how does this affect my ability to work or care for my family, and how much will the treatment cost? So all these factors has to be considered when planning the therapy. Now there are many newer agents that are in pipeline that are undergoing phase 3 trial. That is the RSNs that we have discussed, darolutamide, then the darolutamide alone, enzalutamide plus pembrolizumab, so keynote trial, then the Capitello trial, that is ADT plus abiraterone plus capivasertib. This is done in the de novo patients, hormone sensitive patients who are presenting in the metastatic setting, and the patients who have PTEN deficiency. So this trial is undergoing in our center also, Max. So we have screened around 5 to 6 patients till now. All of them have come PTEN deficient. But if the patient have PTEN deficiency, so both the abiraterone and capivasertib will be provided free of cost under the trial. The others are the talazoparib and the niraparib in the patients who are BRCA mutation positive. So concluding my talk, so treatment intensification with docetaxel or androgen receptor targeted therapy is the new standard of care in these group of patients. ADT alone is no longer the standard of care for the vast majority of men. And intensification is preferred regardless of how fast or how far PSA fall. So the early treatment intensification is preferred to improve the quality of life and disease control. And again, the quality of life and patient preference should be considered when choosing treatment. Thank you so much for giving me this opportunity.
Thank you, Dr. Kanika, for such a wonderful presentation. I think so. You summarized it pretty well, and with the latest options now coming up also. And I would like to now invite Dr. Pankaj, who is a senior consultant in Rajiv Gandhi Cancer Institute, for the next topic. Over to you, sir.
Yeah, thanks, Priyanshu. Thanks for inviting me for this.
And sir, my apologies for making you wait for such a long.
That's okay. It was academic feast. So I'll just share my screen. I hope my screen is visible.
Yes, sir.
Okay. So the topic given to me is current treatment landscapes of metastatic CRPC. So we know that disease progression despite castration level of less than 50 nanogram is considered as a metastatic CRPC, and it is a heterogeneous segment of disease which can be symptomatic, asymptomatic, with or without metastasis, local or systemic, and affects 10 to 20% patients within 5 years of diagnosis of CA prostate. And before the recent therapeutic advances, more than 50% of these patients would have died within 3 years. So progressive decline in health-related quality of life is usually seen, and this is the way the drugs have come into picture, that once the disease is local, we usually go with surgery or radiation, and when there's biochemical recurrence, then we have so many options that we are really confused what to use and when to use. Previously, it was simply some docetaxel, abiraterone, and enzalutamide, but now there are new players in the arena. We have this apalutamide, enzalutamide, darolutamide, which has been tested in first line, second line, and then we have this immunotherapeutic agents, pembrolizumab. So these are the FDA approved drugs, taxanes, and this abiraterone enzalutamide has been there for long. Pembrolizumab came in 2017, and the radiopharmaceuticals we have been using since 2013, not very common. And recent additions were olaparib and rucaparib. For taxanes, I think we are very well versed with this data that docetaxel was the first generation taxane which was used and which was appropriate for castrate-sensitive disease in selected patients. And cabazitaxel was used when the patients were failed on the docetaxel. And cabazitaxel, not a very easy drug to use, not used in the recommended doses usually as 25 mg per meter square. The drug is actually used as around 20 mg per meter square, and even then the chances of neutropenia are high, 40%. And so since most of the patients are already exposed with some chemotherapy and are in extremes of ages, so not a very wonder drug to be used. However, this was the trial which actually tested cabazitaxel versus abiraterone or enzalutamide in metastatic CRPC, whether it should be used first or the tablets, the abiraterone and enzalutamide should be used first. So as we see that the PFS was better when the cabazitaxel was used instead of abiraterone or enzalutamide, and even the OS was better. One factor would have been that not many patients tolerate the chemotherapy after abiraterone or enzalutamide. So not many patients would have been exposed to cabazitaxel in the subsequent lines. So that would be a confounding factor in this trial. But then it clearly states that cabazitaxel preferably should be used before abiraterone and enzalutamide as per this CARD trial. Then we had this COU A301 trial, which was a phase 3 trial of second-line abiraterone in metastatic CRPC. Now, not a very good trial in the sense that the abiraterone was compared to the placebo. So, abiraterone versus placebo, 2 prior chemotherapeutic agents have been tested, and the another one was the AFFIRM trial. Again, it was second-line enzalutamide. Efficacy was seen. Again, the comparator arm was placebo. So we know that these are strong agents, whether you whatever sequence you use, enzalutamide and abiraterone. However, it turned out to show a OS, so it's better to use enzalutamide in subsequent lines if the patient can tolerate. And the tolerance is not major issue, since we know that most common side effects are just fatigue, which are seen in 6 to 7%. So PFS was also definitely better in this, as we see that hazard ratio was 0.40. Then was a phase 3 trial in chemotherapy naive metastatic CRPC, in which he had used abiraterone plus prednisone versus placebo plus prednisone. Again, we see that the p-value was significant. Hazard ratio was 0.31. Overall survival benefit was suggested in this. Another trial, Prevail trial, in which enzalutamide was tested. Again, versus placebo. In this case, again, we see that the OS benefit was there. And similarly was the trend in the PFS, that we can say that you can use either abiraterone or enzalutamide in this chemotherapy naive patient rather than not using anything. Then was the HSPC phase 3 trial of ADT plus minus docetaxel. The charted and stampede, I think, have been covered with the previous speaker. I'll not go into detail of this. So latitude and this stampede trial, all these details have been covered with previous speaker, but we can see that the ADT plus abiraterone was better than using this placebo plus ADT. So this was the phase 1, phase 3 trial, in which they have studied standard of care plus abiraterone versus standard of care, as we can see in the overall population. Overall survival was significant in the sense that it was 5.7 years as compared to 4.7 years, that was 1 year better, p-value being 0.030. So this was a phase 1 trial in which they have evaluated the efficacy of abiraterone versus standard of care. Then we have this much talked about drug darolutamide. I think previous speaker also touched upon this. This was used in combination with a chemotherapy versus using a chemotherapy alone. So this was in the newly diagnosed metastatic castration-sensitive prostate cancer patients. And risk of death significantly decreased by 32.5% with using a combination of darolutamide and the docetaxel, and median OS was not reached. And OS benefit was seen across all the pre-specified subgroups. And time to CRPC was also delayed with the use of this drug. And these 3 trials, Spartan, Prosper, and Aramis, they basically summarize the usage of these agents, apalutamide, enzalutamide, and darolutamide. And if we see the way these graphs are going, they look more or less similar. P-values again look similar. Hazard ratio 0.28 with the apalutamide, and enzalutamide it was 0.29, aramis 0.41. And if we see the improvement in the descent-free progression or death, there was 72% reduction with the apalutamide, similar 71% with the enzalutamide, and then it was the daralutamide, which was 59%. So we can say they are drugs, same class drug, working more or less in a similar manner, though they have not been tested with one another. They have been all tested with placebo. So it's a cross-trial comparison, but looks that they have been doing fine as far as these three drugs are concerned. So if we see the OS, which was a secondary endpoint, again, we see that the graphs are behaving in a similar manner. Hazard ratio, again, hovering around between 0.69 and 0.78. Immunotherapy, Spilsul T, not many people are using, but recently there have been an interest in this outcome of this Spilsul T, in which we see that if you are using this Spilsul T, which was in the IMPACT trial, double-blind placebo-controlled phase 3 trial, OS benefit was seen even without PSA response. So this was useful in less advanced disease if the disease volume is low. So if the patient is very has been already exposed to this enzalutamide, Beratron, not fit for chemotherapy, then these are the patients in which we can still go for something like Spilsul T. Then much talked about drug pembrolizumab in this MSI high or MMR deficient cancers. So this was tested in 5 trials with MSI high. This was an analysis of these combined trials, and the subset analysis we are just going to see that duration of response for CA prostate was 9.8 months, and they were the patients who were PD after previous lines of treatment, and they did not have any satisfactory alternative treatment. So unresectable or metastatic TMB high solid tumors with PD after previous chemotherapy with no suitable alternative. So they can be addressed with pembrolizumab. Then the radium-223 radiopharmaceutical, again not very commonly used. So this is also L-SIMCA trial, in which we see that symptomatic CRPC with bone mets were analyzed, and we see that the median OS with this, previously it was just considered that it will just take care of the pain, but in this analysis it was like survival was better when this radium-223 was used as compared to the placebo, and also the time to first symptomatic skeletal event was improved when this was used. Hazard ratio 0.66. So we know this, unlike beta emitting radioisotopes like samarium-153, which was being used for pain reduction, radium-223 is an alpha emitting isotope, delivers less radiation to marrow, so the side effect profile is better. So we always had a fear that this will cause bone marrow suppression. So with this radium-223, it happens to be better than the previous ones. So then the ERA trial using Beratron plus minus radium. So this did not make really much of a difference. So if we are adding radium to Beratron, this is not of much use as per this ERA 223 trial. Then this was another enzalutamide plus minus radium 223, just like the previous trial they have used in combination. And if we see compare these events, then they seem to be better in this. If we see at 9 months, at 12 months, they seem to be better as compared to using a single agent. And DNA repair gene alteration is common in metastatic prostate cancer. 23% of the patients have these DNA repair alterations, and frequency of DNA repair alteration increased with disease progression. And 11.8% of 692 men with metastatic prostate cancer had germline repair effects. So this was the trial, Profound trial, in which they have tested this olaparib versus Beratron and enzalutamide, which are considered as standard of care. And if you see, the olaparib has done better as far as the PFS is concerned. Hazard ratio was 0.49, and even the OS, if we see, the 18 months OS improved from 39% to 47%, 0.79. So this becomes a strong agent if we have some sort of changes in the genetic level, that the patient is having positivity in this germline DNA repair defect for BRCA. So these are the patients which we can offer olaparib. So another drug, rucaparib, again with DNA damage repair mutations, this was tested in BRCA1, 2, and the germline or somatic mutations. And we see that the median progression-free survival was dependable at around 9 months. So multiple classes of drugs which improve OS in metastatic CRPC include AR pathways, taxanes, immuno, radiopharmaceuticals, and PARP inhibitors are there on a pipeline now. And there's limited information about optimal sequencing, since all of these agents have been used in some manner compared with placebo at times and used in second line, third line. So actually things are not clear that what will be the best one sequence that how you should use. So ultimately we have to tailor the treatment as per the patient's tolerance and the disease volume. And next generation androgen receptor signaling inhibitors improve metastatic free survival in OS in these CRPC patients. And intensification of systemic treatment is now standard of care. So continuum of treatment is the key, that you have to treat these patients as per their tolerance, and that will give the best outcome in these patients. Thanks a lot, Priyanshu. Over to the organizers.
Thank you, sir, for such a elaborate presentation, and that too in such a short time. So I think so you have covered almost all the recent updates also. So thank you, sir. Now I would like to invite Dr. Paneet for the talk. Dr. Paneet is a senior consultant radiotherapist at Paras Specialty Hospital, Panchkula. Dr. Paneet, over to you. He'll be giving us a overview of radiotherapy in prostate cancer.
Thank you, Dr. Priyanshu, for this opportunity. I am very thankful to you in this August gathering of all the medical oncologists. I am the only radiation oncologist, so I will try to present my case. I have made a presentation of the general radiation that is done in CA prostate without going into very specifics. Pooja, can I share my slides?
Yes, sure, sir.
Okay. Are my slides visible?
Yes, sir.
They are not moving. Why?
So do you want to share the slides from your end? Because right now I am sharing the screen.
I would like to, if I can, from my end.
Yeah, sure. That will be great. Okay.
Shall I do it?
Sir, please go ahead.
So I'll share my slides. It's not working. Share screen. Which should I share? Which one should I share? Desktop one or Microsoft PowerPoint? Which one?
PowerPoint, sir.
It's not happening. Chalo, you only do it. I'll tell you. It's not happening from my end. So everybody, good evening. I'll just be very brief. I am Dr. Parneet Singh. I am a consultant radiation oncologist at Paras Hospitals, Panchkula. Next slide, please. So this is the general risk stratification that we do for carcinoma prostate. Very low, low, intermediate, high, and very high. I will not go into the specifics. We all know the risk stratification. Next slide, please. So radiation is helpful in all the risk stratification cases. In low risk as a single modality, in intermediate risk with EBRT and short-term ADT, and in high risk cases of radical EBRT with a long-term 2 to 3 years of ADT, and in palliative settings for bone palliation or brain mets. Next slide, please. So the and then post-op RT as well. Post-op RT includes in cases of PT3, T4, close or positive margins, invasion to seminal vesicles, extraprostatic extension, that is T3, T4, multiple nodes, R1 resection, and in salvage RT, in biochemical recurrences like early recurrence as a salvage or as an adjuvant therapy. Next slide, please. Radiation basically can be given with two techniques, EBRT and brachytherapy. EBRT includes our conventional techniques in which box field was used, and the conformal types, that is IMRT, IMRT, VMAT, and SBRT with IGRT guidance. And in brachytherapy, low dose radiotherapy with radioactive seed implants and HDR brachytherapy. Next slide, please. So basically, also next slide. Yes. So basically, planning forms a very important part of radiation, because in planning we have to do positioning of the patient. Immobilization is done with a cast usually, and we do a full bladder radiation to the prostate, in which we ask the patient to urinate, followed by 300 to 400 ml of water, and then treat it 30 to 40 minutes after that, so that a full bladder can be achieved before radiation. This way, it helps us to push the bowel away from the pelvis and thus out of the radiation field. Preferably, this is the positioning. Next slide, please. This is the conventional portals. These are the APPA fields. The upper border is L5S1 and lower border is this obturator foramen. Next slide, please. Next slide, beta. These are the lateral borders. In this, the anterior border is placed ahead of the pubic symphysis, and the posterior border at the level of S2, S3 sacral pulmonary. These are the old fields that were used. Now they are not used. Next slide, please. These are the three field 3D CRT arrangements, which cause a lot of dose to the bladder and rectum, thus causing late side effects. Next slide, please. So now these are obsolete now, and now only conformal RT is done through IMRT or VMAT or SBRT, as we say. This helps us to actually increase the dose to the treating area and very less dose to the normal structures. The process is that small beamlets are used within the treatment field for dose distribution, and the OIR constraint, that is the OIR constraints, are very strictly followed for rectum and bladder, so that the excess dose doesn't go to these normal organs, and thus patient has very minimal morbidity and short-term as well as long-term morbidity. Next slide, please. This is a plan for conformal radiation. As you can see, the red part is the inner red part is the prostate, our treatment area, and we can very safely, treat the patient without any major dose to the rectum. Next slide, please. We all know that rectum is just posterior to the prostate, and if the rectum is not completely empty, this can lead to geographical miss of the tumor, because you can see in the first photograph, the rectum is collapsed, hence we are able to treat the system, the prostate. But in the next, when the rectum has air filled in it, we have our prostate, this PTV or the prostate target area is missed in the upper end. Hence, we need to have this treatment plan reproducible every day. For that, what we do is we give medicines to the patient so that the rectum is empty and the bladder is filled almost similarly every day, as I told about the bladder protocol. Also, another thing that is done so that the patient is treated properly is a plan of the day treatment. What does it mean? We make 2-3 plans according to the rectal size. Suppose one day rectal is collapsed, we do a planning. In the next day, rectum is a little inflated, we again do the planning. And in this way, 2-3 plans are generated. And when the patient is taken up for treatment, we do the scan, CT scan on the machine that is called as CBCT. And with that CBCT, we try to see which is the plan which is closest to the day's CBCT. And then that plan of the day is implemented. In this way, we are able to give maximum dose to the target and very minimal dose to the normal structures. The next slide, please. These are the various studies which have actually compared 3D CRT with conformal RT. I will not go into the details. Next slide, please. Next slide. And after comparison, we've seen that grade 2, grade 3 GI toxicity of grade 2 to grade 3 is significantly better. Acute, especially acute toxicity, is significantly better for conformal therapy, that is IMRT or VMAT, as compared to 3D CRT. Similarly, late toxicities are also better, and biochemical control is also better as compared to 3D CRT. Next slide, please. Next slide, please. with the passage of time and with more knowledge about the disease, we have come to understand that these prostate is sorry, has an alpha by beta ratio of more than 3, less than 3. So in when the low alpha beta ratio is considered with greater capacity for repair between fractions. Hence, prostate tumors have exceptionally low values of 1.5 to 3 alpha by beta, and thus rationale for dose escalation to increase tumor control while maintaining the same normal complication probability. Next slide, please. These are the various trials which have actually seen compared hypofractionation with conventional fractionation. And next slide, please. Sorry, previous slide. So in all these trials, it has been seen that previous slide, please. In all these trials, it has been seen that the hypofractionation is actually very similar with to conventional fractionation with comparable side effects. And the benefit of hypofractionation is that we can finish the treatment in 5 weeks as compared to 7 to 8 weeks in case of conventional fractionation, thus reducing the hospital times quite significantly. With more advancements, the technique that is now done is SBRT, that is stereotactic body radiation, and this is an extreme form of hypofractionation in which 8 gray per fraction is given for 5 days to a total dose of 40 gray. This is the most common fractionation that is used. Next slide, please. So these are the long-term outcomes from prospective trial with SBRT for low-risk prostate cancer. And we've seen that in this 67 patients were taken and 36.25 in 5 gray fractions were given. Median follow-up of 2.7 years. We saw that very low rate of late rectal toxicity and urinary toxicity was seen. And in 4-year Kaplan-Meier PSA relapse-free survival was 94%, and which is very similar to other definitive treatments of conventional therapy. Next slide, please. Sorry, this is another phase 2 trial, which number of patients was 1100. Median dose was again 36.25 gray in 5 fraction, and it was seen that 3-year overall survival, 3-year median survival with a 3-year median follow-up. Sorry, 335 patients with more than 4-year follow-up was seen, and we saw that that next slide, please. That these were quite significant when it was compared with other patient PSA relapse-free survival for both intermediate risk and high risk was significantly better as compared to other conventional methods or definitive methods. Next slide, please. So the added advantage of SBRT is that in conventional we take around 8 weeks of treatment. Hypofractionation takes 4 weeks, while SBRT takes only 5 weeks. Hence, it is safe and effective, short treatment, convenient for the patient, less hospital visits, less waiting times, non-invasive, and there's no anesthesia or hospital stay involved. And cost is almost the same, but definitely the patient's hospital time decreases significantly. Next slide, please. This is the ASTRO guideline, which was given for SBRT of prostate. ASTRO's opinion, the data supporting the use of SBRT for prostate cancer has matured to a point where SBRT could be considered as an appropriate treatment for select patients with low and intermediate risk disease. The only issue with SBRT as of now is the logistics involved. Not many hospitals have those kind of setups to actually implement SBRT in prostate, because a tumor marker has to be inserted in the prostate and then it has to be followed up every day. So next slide, please. There's the role of brachytherapy as well in prostate cancer. Monotherapy in T1 or T2A, but it is not practiced that much in India. Very few centers are doing it. Next slide, please. These are the radioisotopes which were used for low dose rate brachytherapy. Iodine 125, palladium 103, and iridium 192. Next slide, please. This is the diagram how it is done. LDR permanent seed brachytherapy. Only thing is that the seeds, next slide, the problems with LDR brachytherapy is that travel and contact with adults has to be taken care of very seriously. The first 2-3 months following seed implantation, small children and pregnant females have to be kept away from the patient. Sexual intercourse can start within a few weeks, but should be avoided for at least 3 months. And very occasionally, a seed can be expelled in the semen on ejaculation. If this happens, it should occur in the first few ejaculation. So condoms should be used. Next slide, please. HDR after loading brachytherapy is better than the LDR in the sense that in this patients needn't be away from the relatives. In this, hollow needles are placed in the prostate through the perineum, and soft nylon catheters are placed in these needles, and needles are then removed, but catheters are put in place. Then either with iridium 192 or cesium 137, radioactive iridium is given. This treatment usually takes 2 days, and the last treatment, the catheters are removed. Next slide, please. These photos give us the example of how the patient is during treatment. Next slide, please. These are the doses which need to be given. Next slide. So this is a poem that our Dr. Kanu Chandra Patro, our radiation oncologist from Visakhapatnam, has coined for adjuvant radiotherapy. It tells us that high-risk prostate factors are persistent in blood antigen PSA levels. So seminal vesicle, node, and margin, as well as extra capsular extension, are the indications for RT. Some patients need to start immediate RT. Some can wait. No. Okay, so just touching upon another topic which is quite prominent these days is the oligometastatic carcinoma prostate. Next slide. High volume disease is defined from differentiated from low volume disease by visceral metastasis and or 4 or more bone metastasis, at least 1 metastasis beyond the pelvis vertebral column. Patient, next slide, please. So these are the guidelines given by NCCN in 2022, which even in low volume metastatic disease, EBRT is given to the primary. And this is, next slide, please. This has shown survival benefit in overall survival as per the Stampede. Next slide, please. This helps us in better PFS, better biochemical relapse-free survival, better OS, local symptom control, and toxicities are not that significant. This has been proven in the Stampede trial, M-arm. Next slide, please. These are the radiation sequelae which we face in the OPD clinics every day. There's this burning, urination, diarrhea, urinary frequency increased, rectal discomfort, mild skin irritations, and fatigue. And subacute side effects include chronic diarrhea, bleeding PR, erectile dysfunction, which are not nearly seen with newer techniques like VMAT or IGRT. Next slide, please. The chronic problems are to be taken in account. Some people can have chronic diarrhea, but the most problematic thing is proctitis, because then the patient starts bleeding. For that, we take great care during treatment that we ask the patient to evacuate his bowel before coming to the hospital, so that the rectum is pushed away from the radiation field, and thus patient doesn't have these long-term sequelae. But obviously, radiation sequelae have decreased drastically with the advent of IMRT, IGRT, and VMAT. Next slide, please. So the take-home message is that lower PSA has better outcomes. Dose escalation has been significantly better and has proven to be good for overall survival. Adjuvant and salvage RT after radical prostatectomy both improve recurrence-free survival and offer a second chance of cure. The presence of dose-response relationship supports the use of hypofractionated RT because conventional RT might have an increased risk of recurrence. Next slide, please. Next slide, please. Hypofractionated RT is also associated with improvement in DFS as compared to conventional RT. SBRT or extremely hypofractionated image-guided IMRT regimens can be considered as an alternative to conventionally fractionated regimes at clinics with appropriate technology, physics, and clinical expertise. This is very important because logistics play a very important role when you're doing SBRT. A slight miss here and there can be very detrimental for patient. Hormone therapy along with RT improves survival, and brachytherapy also helps in dose escalation and better disease control outcomes. Next slide, please. So we should, when the patient comes to, you should always do a PR examination, and patient should be comforted so that he doesn't rush out from the OPD. Thank you very much, Dr. Priyanshu. I rushed it a little bit because I think we are running short of time.
Thank you, sir. Thank you so much.
Thank you for the opportunity. Thank you so much, Dr. Priyanshu. Over to you, sir.
Thank you, sir. Pooja, I think so we can conclude now. So I think so we'll conclude now. Thank you everyone for participating, and thank you everyone for giving us the insight regarding genitourinary cancers, and especially in the end we also had some basic knowledge regarding the radiotherapy, which is often the part we tend to, as a medical oncologist, we tend to miss out. So I think so. Thank you, Dr. Paneet, and thank you everyone for participating, and have a nice evening.
Thank
Over
you.
to the
Thank you,
organizers.
everyone.
Dr.
Thank
Priyanshu,
you.
our dinner?
Dinner is, sir, in Chandigarh.
Of
You'll
the
have
house?
to come to Chandigarh.
Dinner is on the house. Everybody's house.
Thank you, everyone.